We are
Welcome,
live now. We are
right?
live now, Doctor. Yeah.
Okay, sir. So welcome everyone for the sixth session of the YOSI iROCK competition, quiz competition. And I welcome all our esteemed judges. So we'll be starting with the presentation and then we'll proceed further also. My slides are visible over here.
Yes, yes.
Okay. So I welcome everyone again. And this is our, we have 5 esteemed judges today and 6 teams and 3 moderators running the show over here for the 6th session of the preliminary session of the YOSI iROCK competition. And this is specifically online competition designed for the residents. The subspecialty for the today will be UVEA. I'll start with the introduction video of the iROCK competition. So, as you see that this is a online quiz competition and this is being organized with the YOSI. The team of the YOSI, the governing council is headed by Devakan Mishra, president, and our past president, Dr. Sunal Kalia, our vice president, Karan Bhatia, our secretary who is present, who has joined us for the today's session, Dr. Nilesh Kumar, and our treasurer, Dr. Aditya Sethi, and joint treasurer, Dr. Prasanna. They are the key members and the key doctors who are managing the governing council of the YOSI. And under their guidance, we are able to do many activities. They are backed up by a very active executive members team for the session of 24 and 26. And we, as an YOSI, it has multiple legs where the YOSI is working, the Young Optimist Society is working, right from the basic education to the end, like medico-legal support also, and also in the form of jobs and fellowship portals. So I'll be happy that the residents will be able to use this platform and exploit this platform to the best of their capacity. This is the team of iROCK, that is Resident Ophthalmic Compact of Knowledge. And as you see, Dr. Nupur and her team has done wonderful sessions till now. This is the 6th session and it's all the driving force behind this whole iROCK is Dr. Nupur Goel, ma'am. And I welcome ma'am again for the team and really happy to see such a lovely online quiz competition over here. This is the YOSI iROCK logo, and I thank from the bottom of my heart to Dr. Nilesh Kumar, who has designed it himself, and it's an amazing thing which we see over here. These are the last 5 sessions of different subspecialties like oculoplasty, glaucoma, cataract, neuroophthalm, which has been covered till now. The YOSI iROCK competition prelims are still, this is the preliminary rounds which are going on and the registrations are still open. So residents, you can share with your colleagues, and if anybody wants to participate further, they can register themselves. I'll go with a brief of the overall of the today's session. Each team has 3 members. Mainly, what we need to concentrate is this is a preliminary round. From here, we will be selecting top 2 teams. And again, then at the end, we will be having 7 finalists who will attend the YOSI annual conference. They will be awarded as YOSI iROCK stars, and they will be competing at the physically at the YOSICon, which is the annual conference of the Young Ophthalmic Society of India, which will be held between 5th to 7th September. And they will be provided travel grants for that. And finally, out of that, top 3 teams will be selected and will be awarded the YOSI iROCK Superstars title over there. So don't forget that even if you are not a part, if you are not even selected, don't forget to attend the YOSI conference, which will be held in 5th to 7th of September. I'm pretty sure this is a very good future platform for all the residents. We'll be having 4 rounds, which first will be seminar presentation named as iLeak. Second will be creative round, which will be which is named as People Got Talent. Then we will be having a quiz round and a wordsmith war rounds, which will be unscrambling of the words. Then between, we will be having audience prizes to be won between the quiz competition of the knowledge nexus. Now, one of the highlight of the today's session is the esteemed judges which we have, the extreme panel of judges. Is I would welcome Dr. S.R. Ratnam ma'am, who has been principal and professor of ophthalmology in Arvind Eye Hospital and has many awards, especially the Professor C.S. Bhaskaran Oration Award and the International Award of the AIS at the AIS 2024. Or along with that, sorry. Presentation is visible?
Yes, it is, Doctor.
It is visible. Okay. So, and ma'am has published many journals and has contributed to many book chapters. It is a privilege that ma'am has been has been nominated one of the top 2% lifetime scientists by Stanford University and has been awarded as unsung hero at the AAO 2020. Next, we have another eminent Dr. Professor Vishali Gupta ma'am, who has been who is an accomplished vitreoretinal and UV expert at PGI Chandigarh. She has extensive lectures, multiple publications, extensive book chapters, and she is the president of International UVEA Society Group Study Group and vice president of VRSI and past president of USI UVEA Society of India. She is the only Indian member to be a part of Club Jules Gonin and first Indian to be the member of the Macular Society. And obviously, she holds 2 US patents and is rated as top 2% of the world scientists in Stanford ranking. Next, we have Dr. Mayur Moreka, sir. I thank everyone again, along with he is associate professor of ophthalmology at Bombay Hospital Institute of Medical Sciences and has multiple degrees along with ophthalmology. He has been he has attained MA in counseling psychology and other medical legal aspects and even healthcare management. He has been the recipient of Dr. V.K. Chitnis Award, Oration Award at MOS conference, has various publications and has various textbook chapters in scientific journal. Especially India interest is as obvious it is an operation. Mandal sir, he has done his MBBS from Midnapur Medical College and Hospital. He is presently HOD and academic in charge at Shoshot Eye Foundation and a DNB exam coordinator of National Board of Examination, and he is currently in Shoshot Eye Hospital Foundation. We have Dr. Tinku Bali, ma'am. She is the senior consultant at Retinal US Society of UVEA Services at Sri Gangaram Hospital.
Dr. Sahil?
I think Dr.
Did-
Sahil has lost his, yeah, he's back. Yeah.
Yes, your slides are visible now. You're muted, sir.
Hello.
Good. Yes.
Yes. Sorry, can I know where did I miss?
You were just beginning with the Tinku Bali ma'am's introduction.
Sorry, ma'am, for the disruption in the internet. I welcome Dr. Tinku Bali, ma'am. She is the senior consultant at Sri Gangaram Hospital, New Delhi, and she has multiple awards, arts into a basket. A few of them are very renowned ones. That is at from LVPI, from New York Eye and Infirmary, and Moorfields Eye Hospital. She has contributed to multiple chapters, and she is the co-author of Basics of Eco-Emulsification. And as a teacher and academics, she has been the guide since 2006. She has also been principal investigator in various multicentric clinical trials. So as we see that we have a panel of judges who are extensively into academics, extensively into publication and research, and it is our pleasure, and we really thank from the bottom of our heart to all the judges who have contributed your time at this Sunday afternoon to attend this session. Now, the moderators, Dr. Nupur ma'am, the ultimate, the super moderator of all the sessions, I would say. And she is currently working in eye care hospitals and PG, Noida, PG Institute, Noida, as an oculoplasty and anti-segment surgeon. She is the executive member. She has been the executive member during 22-24, and now she is the team leader of the iROCK Pan India session as a team leader, and she has been the managing editor of Yo Times. I welcome ma'am for him. Myself, Dr. Sahil Bhandari. I would like to hand over this thing to Dr. Ritu ma'am to please continue further. I will
Thank you,
stop
Dr.
sharing
Sahil.
my screen. Yeah.
You may continue, Dr. Sahil.
Okay. Sorry.
Thank you so much. We have all just been, yeah, yes, it's visible. Yeah, thank you, Dr. Sahil. And we have all these stalwarts from UVEA here and our foundation stone, Dr. Nupur Goyal, with us. You may move to the next slide, please. There are three moderators today. Dr. Sahil, he has done his MBBS and DO from Stanley Medical College and Madras Medical College respectively, followed by his training at Arvind Eye, Pondicherry. He is a skilled eye surgeon and is currently running a 100-bedded charitable eye hospital at Piper City. He has an amazing interest in being connected with academics and henceforth here with us in this session. Next, we have Dr. Priya, has completed her MS Ophthalmology from Gajraj Medical College and has worked as senior resident at Shivpuri Medical College. She has just completed her fellowship from the Cornea Subspecialty from Sadguru Netra Chikitsalaya, Chitrakoot, and is currently affiliated as a consultant at the Retina Specialty Hospital, Indore, MP. Lastly, this is me, Dr. Ritu, and I have been an alumna of GSV Medical College, Kanpur and KGMU, Lucknow. I have over 25 presentations at national and international fora, and apart from winning best paper presentations at DOS and UKSOS, I'm also a recipient of AIOS IGO Silver Award. We are going to have an amazing session today indeed. Thank you so much. I move next to Dr. Priya. Please welcome the participants.
Okay, so good afternoon, everyone. So today our participants are Team 1, the Vogt trial from Dr. RP Center, AIMS, New Delhi. So we have Dr. Suhana Alam, Dr. Punya Muralidhar, which is captain, and Dr. Diksha Singhal. So we welcome you. The second team is Visionaries from Dr. SN Medical College, Jodhpur. We have Dr. Somita, Dr. Priya Tyagi, the team captain, and Dr. Bhavna Verma. The third team is 2020 Visionaries from Eye Care Eye Hospital and PG Institute, Noida. So we have Dr. Shreya Raj Singh, Dr. Nibha Gupta, Captain, Dr. Preeti Suman. Next team is the Site Squad, Little Flower from Little Flower Hospital, Anagmali. We have Dr. Anjita BS, Dr. Shine NS, team captain, and Dr. Aisha Sana. The next team is the Arlt Triangle from RP Center, AIMS, New Delhi. We have Dr. Pooja, Dr. Kirtana, the team captain, and Dr. Aniki. Our next team is Site Seeker from KGMU Lucknow. We have Dr. Anji Jain, Dr. Anvi Laksh, team captain, Dr. Ritik Jain. So we welcome you, and we have their mentors to support. So from the team Vox Trio, we have invited Dr. Nawazi Sheikh. We welcome you, sir. From Team Visionaries, we have Dr. Ramesh Chopra. From Team Site Squad, we have Dr. Risha K.R. From Team 2020 Visionaries, we have Dr. Unnati Sharma, ma'am. And from Site Seekers, we have Dr. Arun Kumar, sir. And from Arts Triangle, we have Dr. Ambar Vyana. So we welcome you all, and thank you so much for joining us today. Coming to the YOSI GC support and guidance, we are very thankful to the team. And here we have the team Governor Council. So we have Dr. Divakan Mishra sir, Sonal Kalia, Dr. Bhatia, Karan Bhatia sir, Dr. Nilesh Kumar sir, Dr. Aditya Sethi, and Dr. Prasanna Ramesh.
Dr. Nilesh Kumar, sir, please,
Uh,
we would love to have
Thank you
an
so
opening remark from you.
Thank you so much, Dr. Sahil, Dr. Priya, and Dr. Ritu. And first of all, a big shout out to Nupur ma'am because this was a mammoth task when she started, when we asked her to do this in September. And she alone could have led this because it requires so much of coordination across the country to all the PG institute and finding who the teams, sorting them into their respective subspecialty and then getting everything all together. And also my extreme gratitude to the stalwarts of UVEA, those are here, because without their guidance support, the quiz would not have happened. And I would like to extend invitation to each of the judges from Team YOSI that please be with us in September at YOSICon, where we will have grand finale and you can see the people you have selected in action, and also to support them and award them when they win. So it will be my humble request to each and everyone. We will reach out to you, each one of you individually also, and seek your topics and your participation for the same. All the best everyone for that, and all the best to all the teams also. Looking forward to this great quiz.
Thank you so much, sir.
Okay. So now we are moving up to the next part. That is the now we'll be moving on to the main game changing event which will be going on. So first I'll give a small outline about the sessions, which are all the sessions. So round one will be seminar. Each team will be presenting one presentation from their side. The round two will be a people got talent. They will be presenting some kind of video, some kind of creative activity. Each time will present one from each team. Then we will be having quiz. There will be 10 questions in the quiz, which will be multi-specialty. And at the end, we'll be having wordsmith war. For each team, there will be a set of six jumbled up words for them to solve it. So now we are starting with the first round. This is the seminar round. I request all the judges, ma'am, we have already shared that mark sheet. So this the mark sheet has both the parts. So in that basis, please do give the marks at the end of the presentation. Each presentation will be followed. Each presentation will be of 5 minutes exactly. So team members, please make sure whoever is presenting should not do not exceed more than 5 minutes because that will attract negative marks. Then one team member will only be presenting. So do not log in from multiple devices so that there will not be any confusion during the presentation. And at the end of the presentation, there will be around 1 to 2 minutes per judge session of question and answer. Maximum is 20 marks. And the today's topic will be specialty based, that is UVEA. This will be the sequence of the presentations. So as per the team, these are your numbers also for the further rounds also. So keep a note of it. So now I welcome first the Vogt trio team to start with their presentation. So I'll be unsharing the thing and then please you share your own screen. Vogt trio team, please.
Yes, sir, we are sharing. Just a minute.
Slide share, please. And then I shall begin the timer.
We are unable to hear your audio.
Good afternoon, all. Our topic for today is Fuchs heterochemic iridocyclitis, which was first described by Austrian ophthalmologist Fuchs as a triad of iris heterochromia, unilateral iridocyclitis, and cataract. It was seen in 2 to 11% of all patients with uveitis in early to middle age with no race or gender predilection. Etiology proposed were sympathetic dysfunction, rubella infection, toxoplasma infection, cytomegalovirus infection, HSV infection, chikungunya virus infection, immunological theory, and muscular theory. Sympathetic dysfunction leads to decreased nerve supply to melanocyte, causing reduced number of melanosomes and tyrosinase activity, and it also causes disruption of blood-aqueous barrier and exudation of proteins and inflammatory cells in anterior chamber, both of which lead to iris heterochromia plus cyclitis. Infectious causes. Evidence for rubella virus infection in patients of Fuchs has been seen by detection of oligoclonal antibodies from the aqueous humor of these patients and reduced number of Fuchs cases post rubella virus vaccine introduction in West countries. Toxoplasma infection, as it causes the chorioretinal scars. Similar scars have been seen in patients of Fuchs. Vascular theory proposes improper hyalinization of vessels leading to their leakage and inflammatory cells entry into the anterior chamber, which causes long-term inflammation. Immunological theory states both humoral and cellular immunity are involved. Cellular immunity, due to the destruction of iris and ciliary body by the pre-existing infectious agent, there is a reduced production of TGF-beta, which disturbs the anterior chamber associated immune deviation, and it also causes reduced expression of intracellular cell adhesion molecules and an MHC2 expression on iris resident cell, leading to more influx of inflammatory cells and iridocyclitis. Symptoms are diminution of vision, lightening of iris, blurry vision with pain and colored halos, floaters. Signs commonly seen are stellate keratic precipitates, heterochromia, cataract, neovascularization iris but no peripheral anterior synecdoche, and iridocyclitis, which involves anterior chamber and anterior vitreous. Iris heterochromia seen in 75 to 90% of the patients where lighter iris is the affected one, which is preceded by iris atrophy, giving a moth-eaten appearance as shown in the figure on right-hand side. As shown in figure below, iris depigmentation can be varied, which can be slight to obvious and finally striking. Inverse heterochromia is seen in patients having lighter iris in which the darker iris is the affected one. Keratic precipitates, they are stellate and diffusely distributed over entire endothelium as compared to other anterior uveitis where they are generally clustered in the Arlt triangle. Low-grade iridocyclitis, which is non-responsive to steroids without posterior synecdoche, and mild vitritis without macular edema is a feature of inflammation seen in Fuchs patients. Cataract is seen in 75% of the patients with Fuchs, which can be posterior subcapsular, and finally it can progress to total white. Iris rubeosus, which can be seen as fine vessels traversing the trabecular meshwork as seen in the photograph on the right hand side. These vessels during the cataract surgery, when paracentesis is made, sudden decompression of the anterior chamber can lead to leakage of these vessels, producing Emsler-Verey sign. And finally, toxoplasma-like chorioretinal scar can be seen on fundus examination of these patients. Diagnosis. The diagnostic criteria for Fuchs has 3 essential findings and 5 associated findings. All the 3 essential findings are must for making a diagnosis of Fuchs, which involve diffuse iris depigmentation, absence of posterior synecdoche, and mild inflammation in anterior chamber at presentation, which include stellate medium-sized keratic precipitates and minimal cells and flare in the aqueous. Associated findings are unilaterality of involvement, cataract, vitreous opacity, absence of acute symptoms, and characteristic iris nodules. Further, we can confirm our diagnosis by the in vivo confocal microscopy, which shows the most classical dendritiform keratic precipitates, here shown in the C figure. Differential diagnosis of Fuchs are the most important one is the Posner-Schlossman syndrome, which presents with unilateral recurrent attacks of mild anterior uveitis with marked elevation of IOP in the range of 40 to 60 millimeter of mercury, which responds excellently to steroids and topical anti-glaucoma medications. And in between the attacks, IOP and facility of aqueous outflow are usually normal, whereas Fuchs has a mild uveitis as a single protracted course, and IOP elevation occurs as a late complication. Herpetic keratouveitis has severe iris atrophy leading to transillumination distribution defect, and mutton fat keratic precipitates in Arlt triangle. Other are congenital iris heterochromia, congenital horners, and diffuse iris melanoma. Management: 83% of the patients achieve vision of 6/12 after cataract surgery. 27% patients benefit with medical management. 67% is the survival rate of TRAB, and 94% is with GDDs. Inflammation can be controlled with topical and systemic steroid. Thank you.
Superb. So we shall end the timer. So I would like now, after this particular presentation, we would like to invite one by one judges for the question answer session. I would like to first invite Dr. Ratinam Madam to ma'am, please ask the the students the any question and answer from your side.
Okay. Very good presentation. I really appreciate the way she has prepared the slides also. Do you think there is always a typical fuchs or there are few atypical fuchs also? Am I audible?
Yes, ma'am, you are audible.
Yeah.
Vogt's people, please answer ma'am's question.
Ma'am, there are atypical fugues in which there may not be unilateral but bilateral presentation with more inflammation, and IOP rise may be there from initial cases only.
Yes. What is the reason you think you have atypical presentations?
Yes, ma'am.
What is the reason we have atypical presentations? Because the etiology may be varying. No, that is the reason. Okay, good. Very good.
Thank you, ma'am. Further, I would like to move to Dr. Vishali, ma'am. Ma'am, please give your question answers.
Just to interrupt, just 1 second, ma'am. I'll request the team members to keep your videos on when you're answering the questions, please. Mokshayo, please keep your video on. Yeah. Yes, ma'am. Ma'am, please proceed.
Yeah, thank you for good presentation. I have a couple of questions for you. You said 90% of the patients would show heterochromia. In your experience in RPC, how many patients you see with heterochromia?
Ma'am, in Indian patients, heterochromia is appreciated lesser due to the darker iris in our people. It is more appreciated in the Western population.
That's true, because the literature you have shown are majority of them are not pertinent to Indian context. So heterochromia is virtually being removed out of the fuchs because heterochromia is not seen in brown iridus. My second question to you, you said differentiating it from Posner-Schlossman and fuchs, and Posner-Schlossman would respond beautifully to steroids and the fuchs will not. I'm sure you are from RPC and you would be aware that Posner-Schlossman in majority of the cases has now an etiology, which is CMV. So I did not see you differentiating fuchs from CMV or herpes anterior uveitis, which would be my major concern. Any thoughts on that?
Ma'am, I did differentiated fuchs from herpes anterior uveitis. I showed the photographs where the iris atrophy in herpes anterior uveitis is much more severe, leading to iris transillumination defects. And the keratic precipitates in herpes uveitis are mutton fat keratic precipitates, which are there in Arlt triangle, whereas in fuchs they are distributed throughout the endothelium.
No, herpes doesn't show Arlt triangle. We'll talk about it some other time. I I think there is a time limit to the questions which I can ask. But I would just want to say 3 points. One, don't look for heterochromia in fuchs. Second, don't treat patients with steroids. It's not that they will respond to steroids. Steroids are not required for fuchs. Third, vitreous, debris, and floaters is a very common manifestation of fuchs. So please do not confuse it with intermediate uveitis. If you do fluorescein in these patients, you will see disc hyperfluorescence, but you will never see CME unless you have done a cataract surgery. And that helps you. And fourth, we see it day in, day out, Fuchs being confused with viral interior uveitis, which is a very broad topic. I will not touch it, but it's very important to differentiate the two. Thank you.
Thank you, ma'am, for the beautiful insights and the knowledge which we have shared. Now, I would like to welcome Dr. Mayur sir for the question answer session.
Good afternoon. Thank you, Sahil. Good presentation, Dr. Suhana. Only one question. Would cataract surgery be considered safe in patients with Fuchs in comparison to the other types of uveitis like, say, HLA-B27 uveitis?
Yes, yes, sir.
So you think it would be safe to do a cataract surgery?
Yes, sir. As compared to other uveitis, because there is a low-grade inflammation in Fuchs, cataract surgery is safer.
Very good. Sahil, you can move on to the next.
Sure. Superb. Now, I would like to invite Dr. Tinku ma'am, for further any questions.
So excellent presentation. I'd just like to ask you a few questions about the iris. What is the pattern of iris atrophy? Which part of the iris stroma is involved? And also you said that there could be iris new vessels. So are these actually iris new vessels or is it something else? How would you describe these abnormal vessels? Is there new vascularization of the iris in these patients?
Ma'am, the iris atrophy is classically described as moth-eaten appearance. There is atrophy of anterior iris stroma, due to which the posterior pigment epithelium, the anterior non-pigmented epithelium becomes visible, leading to heterochromia. And could you repeat the second question? Could you please repeat the second question?
Is there iris new vascularization as well? You said iris new vascularization in your presentation. So is it a true?
No, ma'am, I don't think there is neovascularization iris, but
Not true. It's not.
it's not true.
So what neovascularization do you see, and how would you what is the typical
Neovascularization angle is present.
What would you see on gonioscopy?
What would you say?
Fine vessels traversing the trabecular meshwork.
Great. Okay. And also sometimes you may see the normal iris because of the atrophy of the iris stroma. You could see the normal iris vessels, peeping through. So it's not actually an iris neovascularization that you see, it would be the normal iris vessels. And again, like Dr. Vaishali said, the new terminology is now, the heterochromia is removed from this because we hardly see any heterochromia in our Indian population. And the new term is like Fuchs uveitic syndrome it's more appropriately called that now. Thank you. Thank you. Excellent presentation.
Oh, superb. I would appreciate that at least answering almost most of the things. Very good. And lastly, I would like to invite Dr. Somaya Mandal sir for your question answers.
So first of all, congratulations, because within 5 minutes, completing Fuchs is very difficult. So you have done a great job, and almost all the theoretical part is covered. I want to ask you that whether you have seen Fuchs patient in your OPD or not. So what would be the ideal profile where you can suspect a patient that this patient can be a patient of Fuchs? What will be the patient's profile?
Sir, I have seen a Fuchs patient in my OPD. The patient was middle-aged male with no history of trauma or steroid use, but he was having unilateral total white cataract with few cells in anterior chamber. And when his cataract surgery was being performed, at that time, Emsler sign was also visible.
Right. So the thing you have to keep in mind that a young patient with a unilateral cataract, because uveitis, you may miss uveitis part because it is very subtle. So unilateral cataract in a young patient, always think of Fuchs first. And the second is if posterior segment examination is required or in a Fuchs patient, what do you think? Can you understood my question? Posterior segment examination is required in a Fuchs patient or not? Whether
it is required. It is required.
Okay. What finding will you expect in a Fuchs patient?
Stringy vitreous with vitreous debris and no macular edema.
Okay. Great. Thank you. Thank you so much. I have completed.
Thank you, everyone. Thank you, all the judges. Now we will move up to the next team, the Visionaries, who will be presenting, giving up their present. Before that, I would like to invite the mentor of the Vogt's trial team, Dr. Nawazish Sheikh, sir, for your kind words and appreciation on the presentation, sir. A minute for your discussion. Dr. Sheikh, sir.
So good afternoon, everyone. Dr. Nawazish here. So I found their presentation was exceptional. I could see their teamwork reflect in each part that all of them did. And I'm extremely excited to know what happens with this team. And they're one of our best residents at RP Center. And I wish them all the best.
Thank you. Thank you so much, ma'am. Thank you for their appreciation and motivation to them. Now, next I welcome the Visionaries teams, the second team. Please share your presentation. Timer.
Please begin. Team, I'm resetting the timer. You're not audible.
Sir, should I start?
Start, please.
A very good afternoon to all. Here I'm Dr. Bhavna from the team Visionaries, going to present on the topic acute retinal necrosis and progressive outer retinal necrosis. Comes to the introduction. It is an infectious pan-uveitis condition which is potentially visually devastating. It caused by the herpetic virus family. Most common causes are HSV1, HSV2, and varicella zoster virus. Coming to the clinical features, it involves both male and female equally at two peak ages. That
Just
is
one
around
second. I think your screen share is not proper.
Yes, the
Sahil and
present-
Ritu, do you want to screen share it again?
Yeah, I think I'll try to share this. This is getting cut off.
Yes,
Cut off.
yes.
Just hold on. Just stop sharing your screen, please.
Okay.
I'll just switch on your presentation. Wait.
You have it, Sahil, or should I share?
Yes, I have.
As Dr. Sahil moves the slides, the speaker can just say next if you wish to change the slide. Also, post presentation, please switch on your videos.
Is it visible
I've
now?
Okay,
paused
ma'am.
the timer.
Okay. Yes, sir. It is visible.
The whole slide is visible properly?
Yes, sir. Yes, sir.
Okay, let's
So
start
you
the
need to reset the timer as well, please. Yeah.
Okay. A very good afternoon to all. Here I'm Dr. Bhavna from the team Visionaries, going to present on the topic acute retinal necrosis and progressive outer retinal necrosis. So please change the slide. Comes to the introduction, it is an infectious pan-uveitis condition, which is potentially visually devastating. It caused by the herpetic virus family. Most common causes are HSV1, HSV2, and varicella zoster virus, whereas CMV and EBM are the rare causes. Coming to the clinical features, it involves both male and female equally with two peak age groups. That is, first is around 20 years and second one is around the 50 years of age. It usually occurs in the immunocompetent patient and usually it is a unilateral condition. So 35% of 35% untreated patients of this condition will in 35% untreated patient of this condition, other eye is also involved within 5 days to the 30 years, and it can be reduced by antiviral treatment, and it is more common in HIV patient. What happens here is the infection from the infected eye travels to the CNS through the parasympathetic system of oculomotor nerve. In CNS, this infection replicates in the suprachiasmatic region of the hypothalamus. From there, the infection travels to the unaffected eye through the retrograde axonal flow. Now comes to the pathophysiology. Once the eye gets affected with the primary infection or reactivation, it will cause fibrinoid necrosis of vessels, vascular occlusion, and ischemia, and it disrupts the blood retinal barrier, which will lead to full thickness necrotizing retinitis, and which potentially cause the retinal detachment. Now comes to the symptoms. Patient comes with pain, redness, photophobia, floaters, and blood vision. As the disease progresses, vitritis and necrotizing retinitis will also be seen. Coming to the signs, because of the anterior segment involvement, there are signs like corneal edema, keratic precipitates, AC cells or flares, posterior synecdoche, and raised IOP. Vitritis is the significant sign in the posterior segment signs. As you can see in this slide, as you can see in the next slide, here are the fundus photographs of various conditions. Like first one is of the vitritis, where the media is completely hazy. The second one is of the retinal arteriolitis. Here you can see the ischemic retinal arteries, and the last one is of the multifocal retinitis, where you can see multiple foci of the retinal necrosis. American Uveitis Society has laid down a criteria for the diagnosis of ARN, which is solely dependent on the clinical findings, and it is independent of the etiological agent. Coming to the next slide, here are the approaches for the diagnosis of ARN. It is purely based on the clinical features of the patient. Atypical and difficult diagnosis cases may need to the support of the other diagnosis, like we can go for AC or vitreous tap, or we can also go for PCR. Coming to the treatment modality, in treatment we can go for in treatment we control infection through the intravenous antiviral therapy, in which acyclovir is the mainstay treatment. We can also use oral antiviral. In this, we can use tablet acyclovir, valcyclovir, and famciclovir. We can also go for intravitreal antiviral therapy like foscarnet and ganciclovir. These patients also require anti-inflammatory therapy because there is a severe intraocular inflammation, which will lead to vitritis and optic neuropathy. We can use oral steroid under the coverage of antiviral treatment. These are coming to the next step. These are the differential diagnosis of this condition. I'm going to talk about one of them, which is progressive outer retinal necrosis. Progressive outer retinal necrosis, it is more common in the immunocompromised patients. Here, media is relatively clear. Location and position of the retinal patches are more around the macula, and then they progressively involves the full thickness of the retina. Blood vessels appear uninvolved here, as you can see in the given pictures clearly. Let's talk more about this condition. It is a multifocal necrotizing retinopathy caused by varicella zoster virus. It is more common in HIV patients having profound CD4 count less than 50 cells per mm², and it is generally bilateral. Now coming to the symptoms, patient comes with painless loss of central vision. It has a rapid progression and minimal floaters. If I'm talking about the signs, you can here see multifocal yellow-white necrotic lesion as it is clearly visible on the pictures I have mentioned in the slide. And these yellowish white necrotic lesions are called cracked mud appearance. Coming to the differential diagnosis are acute retinal necrosis, CMV retinitis, and syphilitic retinitis. In syphilitic retinitis, you will see a ground glass retinitis in the fundus on the fundus examination. Coming to the diagnosis is purely depend on the clinical features. In atypical cases, we can go for PCR and AC and vitreous tap. Talking about the treatment goals, we can identify the risk factors, improve immune system, treat ocular and systemic infections, and manage complications. In treatment, we can use heart therapy in HIV patients. We can also use IV cyclovir, intravitreal foscarnet, and ganciclovir implants. Retinal detachment is seen in 70% of patients having progressive outer retinal necrosis, and 67% of patients land up into no perception of light despite of using the treatment. Thank you.
You may stop sharing your screen, Dr. Sahil. Thank you, team Visionaries.
Yes.
I'll
Okay, so now I invite one by one again judges for the question. First, I would like to invite this time Dr. Soumya Mandal sir for the question answers to the team. The team, you need to yes, please your video should be.
So again, I will ask you about the practical things. Practically, what you will see, or you have already seen any patient of ARN or PORN in your clinic or not, so that it will register.
So yet I haven't seen any patient of ARN, PORN in my clinic.
Okay, so presentation is really excellent. So what will be the treatment options in a ARN patient?
Sir, we can go for intravenous antiviral therapy. In that, we can use acyclovir, 10 mg per kg for 5 times a day, and we can also use intravitreal injections. But intravitreal therapy is not suitable for the. It is a local treatment. We can't use it. We can use it generally. It is not a mainstay treatment. Generally we go for intravenous antiviral therapy and oral antiviral therapy.
So associated with that, you have to keep in mind that these patients may be immunocompromised also. So your treatment of HIV or the main disease which is for which the patient is getting treatment, that is also important. Immunity status of the patient is also important. Thank
Yes,
you.
sir. It is important to check the status of the patient first and check whether he is taking any immunosuppressant or not.
Right. And one controversy is there about doing a laser in the retina holes. Previously, we used to do laser. What will be your comment on this? Are you aware of?
Sir, it's a controversy to use a photocoagulation laser in such condition to prevent the retinal detachment.
So previously we used to do lasers, but nowadays laser is very much controversial because laser itself can cause a retinal hole, because almost all the retinas are necrosed retina. So that is a issue. Thank you. Thank you for my.
Thank you so much. Thank you so much. I would like to now invite next Dr. Tinku ma'am for the question answer session.
So team Visionaries, that was a very comprehensive presentation. I think you had too much information to give, about all the disease entities. They're all very big topics in themselves. So my question to you is, how would you differentiate a retinitis from a choroiditis? Very basic question. These were all retinitis cases. So how would you differentiate it?
In retinitis, patient generally comes with the blurred vision.
No, clinically, when you see a patient, when you see the fundus, how would you know it is a retinitis and not a choroiditis? The margins of the lesion.
Yes, ma'am. In retinitis, we will see a pale disc on fundus examination.
The lesion itself. I'm talking of the thing that when you see an ARN patient, you see the area of necrosis in the retina. So how would you know it's not? Anything about the
occlusive arteriolitis.
Okay.
Ma'am, media will be hazy.
What about the margins? How will you differentiate choroiditis from retinitis?
Ma'am, in retinitis, there will be occlusive arteriolitis. There will be ischemic retinal arteries.
No, that's not what. So I think you need to go and look that up. So the margins in a choroiditis will be very well differentiated, while in a retinitis, the margins are going to be very fuzzy. Also, the level of the lesion. So retinitis will be more superficial. Choroiditis lesions will be more deeper placed, more well demarcated. So that is the basic thing. And also, since you've not seen a patient of ARN, but you've seen book pictures, how would you describe the characteristic lesions in an ARN, a patient of ARN?
Ma'am, generally in ARN, lesions are, ARN condition, lesions are at the periphery they come together and coalesce and involve the full and involve the whole area.
What is the shape?
They have a centripetal progression.
Fan-shaped or wedge-shaped lesions. Okay. And what are the other differential diagnoses you would think of a peripheral retinitis like this? Any differentials you would think of? Atypical presentations of some other inflammatory pathologies.
There could be CMV retinitis, toxoplasmosis retinitis, endogenous endophthalmitis, and
I think tubercular and toxo are two other differentials where you could consider in a peripheral retinitis like this. Okay. And just my last question, what are the causes of visual loss in a patient of ARN? A patient suddenly comes to you with a loss of vision. A patient who's under treatment and is doing well.
Ma'am, because yes, ma'am, this condition leads to the fibrinoid necrosis of the retinal vessels, which will ultimately lead to the retinal detachment, which is the main cause for the vision loss in this patient.
And another cause could be optic atrophy. There's also an optic neuropathy going on with this. So optic atrophy is another cause of loss of vision apart from a retinal detachment. Thank you.
Thank you so much, ma'am. Next, I would like to invite Dr. Mayur sir for the question answer session.
Yeah, thank you, Sahil and Bhavna. Excellent presentation. Very well done to summarize everything in about 5 minutes. I'll again ask you only one question. So you said that these are seen more in immunocompetent patients. Now in renal patients, patients with chronic kidney diseases, where you said the drug of choice is intravenous acyclovir. Would a dose adjustment be required? And what are the other oral drugs that one can use? Think you answered this question in your PPT. So think over and let me know which are the oral drugs that are used in renal patients.
Sir, we can use valcyclovir, oral valcyclovir drug, sir, because it has an excellent bioavailability.
And the other drug?
Sir, other drug could be ganciclovir, foscarnet.
You named it in your presentation. The other drug is famciclovir. Famciclovir is typically used as 500 milligram thrice a day. So when you have a patient with CKD who has ARN, and of course you take the help of the nephrologist, they would generally prefer this drug because it has almost the same bioavailability. Okay. Anyway, very nice presentation. Sahil, you can move on to madam.
Sure. Thank you, sir. I would like to invite now Dr. Vishali ma'am for the question answer.
Thank you, team, for the excellent presentation. My question to you. You are sitting in an OPD and you see a patient where you suspect ARN. What will you do, given all the knowledge that you have?
But first, I will go for the fundus examination.
That's okay. You suspect ARN. What will you do?
I will do the systemic workup of the patient.
So, which
after the
TB talks, you will rule out everything?
With the help of the, I can, if I'm suspecting the patient is having an ARN, then I can start him or her on an empirical treatment to prevent the vision loss.
What is the empirical treatment?
Like, ma'am, I will start patient on oral antiviral drugs.
Yeah, that's the key home message, that once you suspect ARN, you start antiviral treatment straight away, And the other, even if you have some differentials, that needs to be ruled out later. You do not have the luxury of the time to rule out the other differentials before starting therapy. Okay, thank you.
Thank you so much, ma'am. I would like to invite now Dr. Ratina ma'am for the question answers.
Only one question, very short question. What is the type of KPs you see in AR?
Sorry, ma'am. Could you please repeat the question? I
KP,
was not able to.
Type of KPs in ARN.
Ma'am, granulomatous, generally granulomatous KPs are seen in such conditions.
Yeah, acute granulomatous. Acute granulomatous is very typical in ARN. Okay, thank you. Thank you.
Thank you. Thank you, all the judges. I would like to now invite the mentor of this team, which is Dr. Ramesh Chopra, sir, for your kind words and motivation. Dr. Ramesh, sir.
First of all, congratulations. Thank you to UC team. The great job. This is very nice. But theoretical part based.
Okay.
Dr. Ramesh, I think your audio was cracking. If you can, yeah, or maybe we can take, yeah.
First of all, thank you to all UC for initiative. And the presentation was very good. We covered theoretical. So it's all the best for your win. Thank you.
Sure. Thank you so much. Thank you, sir. Now we move on to the third team, which is the 2020 Visionaries team. Please you share your screen and start your presentation.
Okay, sir. Is it visible, sir?
Yes, it is visible. Yeah.
Sir, can I start?
Yes.
To timer, please.
Good afternoon, everybody. Topic for my today's presentation is uveitis in juvenile idiopathic arthritis. I will be covering under these headings. So let us understand first what is juvenile idiopathic arthritis. It is an arthritis of at least 6 weeks duration without any identifiable cause and children younger than 16 years of age. This is the most common cause of uveitis children, accounting up to 47% of all the type of uveitis seen in children. Coming to etiology, we know it is idiopathic, but it has been found that the interaction between some environmental factors and multiple genes have a role. Development might be initiated and sustained by the exposure to environmental factors. Different external agents elicit multiple antigen-specific pathways, cytotoxic T-cell responses, activation of classical complement cascade, and production of pro-inflammatory cytokines. Coming to the classification, juvenile idiopathic arthritis is classified by the International League of Association of Rheumatology according to the extent of joint involvement during the first 6 months. And they have broadly classified into 7 types. The first one is the oligoarticular. It is the most common type involving 4 or fewer joints. Girls to boys ratio is 5:1 and large joints are mostly affected, knees being the most common. The peak age of presentation is 2 years and they have 75% of ANA positivity and 20% of them will develop uveitis. The second one is polyarticular and juvenile idiopathic arthritis with rheumatoid factor positive, involving more than equals to 5 joints and they resembles adult rheumatoid arthritis. The next one is rheumatoid factor negative, polyarticular juvenile idiopathic arthritis involving more than equals to 5 joints with girls to boys ratio of 3:1 with peak at, it occurs at any age with 40% of ANA positivity and 5 to 10% will develop uveitis with milder systemic features. The next one, the fourth one is systemic juvenile idiopathic arthritis, also known as Still's disease. It presents with systemic features which may precede the arthritis with equal preponderance in girls and boys. It occurs at any age with ANA negativity and it rarely develops into uveitis. The last 3 are the less common forms, which are enthesitis-related arthritis, psoriatic arthritis, and undifferentiated arthritis. Coming to the clinical features, they are asymptomatic, detected by screening with slit lamp examination. Conjunctival injection is usually absent. The inflammation is chronic and non-granulomatous. They present bilateral symmetrical. In acute stages, they present with endothelial dusting and hypopyon will not be there. Posterior synically is usually seen. Coming to the complications, the most common being the band-shaped keratopathy and cataract, the glaucoma followed by the glaucoma, amblyopia, maculopathy, cyclitic membrane, and phthisis. Investigations, the systemic diagnosis and management by a physician, especially pediatric rheumatologist, anti-nuclear antibody testing, HLA-B27 testing, and rheumatoid factor testing. The main thing is the uveitis screening schedule for patients with juvenile idiopathic arthritis. Eye examination every 3 monthly for patients with the following characteristics, which are oligoarthritis or undifferentiated arthritis, ANA positivity, juvenile idiopathic arthritis onset before age of 7 years, or GIA diagnosis 4 years or less. Eye examination every 6 to 12 months for patients without the characteristics listed above. Importantly, the information for the parents, the importance of the compliance with the screening, as well as the need to seek urgent advice should be there for any cause for concerns such as visual symptoms, ocular redness, or clouding, or abnormal pupils. The self-monitoring at eventful discharge from screening by checking the monocular vision at least once a week. Coming to the differential diagnosis, idiopathic juvenile chronic iridocyclitis, the other types of juvenile arthritis, and uveitis, including the juvenile reactive arthritis, juvenile inflammatory bowel disease associated arthritis, juvenile sarcoidosis, Lyme's disease, intermediate uveitis, masquerade syndrome like retinoblastoma, and familial juvenile systemic granulomatosis. Treatment is, the main aim of the treatment is suppression of all the active inflammation. So we will prescribe them topical steroids, mild mydriatic agents like cyclopentolate, periocular steroids, oral steroids, and non-steroidal anti-inflammatory drugs. Systemic immunosuppressive agents such as methotrexate, infliximab, and adalimumab should be considered at an early stage under the guidance of uveitis specialists and pediatric rheumatologists. Etanercept should be avoided as it worsens the inflammation, and tocilizumab is given in the refractory cases. Treatment of secondary glaucoma and cataract if present. Thank you.
Superb. Dot on time. Very good. So now we will go, we'll move. You can stop sharing the screen and.
Okay, sir.
Yeah. So I would like to now invite Dr. Vishali ma'am for her question answers to the team. Please team, keep your video on. Yes.
Yes.
Really? You were really on time. So my question to you, what are the common clinical presentations that these children might come to you?
Ma'am, generally these patients remain asymptomatic, but they come to us either by the parents with squint, or they have when they develop low vision or amblyopia. And
complicated cataract.
Cataract and any band-shaped keratopathy if they develop.
So how would you manage complicated? Suppose you are seeing a child who has band-shaped keratopathy, cataract, ANA positive, never been treated before. How will you manage?
Ma'am, first we'll see if there is any active inflammation is present or not. If there is any active inflammation, we'll treat for that. And before going for a cataract surgery, if the band-shaped keratopathy is severe, we'll treat for band-shaped keratopathy with adulation with EDTA. And for cataract, at least 3 months of 3 months of steroid treatment should be given. For inflammation should not be there to suppress the inflammation, and after that only we can go ahead with the cataract surgery.
And what kind of implant would you put?
Ma'am, acrylic IOL.
For all?
Yes, ma'am.
Okay. Thank you.
Thank you.
Thank you so much, ma'am. Now I would like to invite again Dr. Ratinam madam for the question answers.
Am I audible?
Yes, ma'am, now audible.
All these children have good prognosis after some time. And what is the age? Or when will you do surgery in these patients?
Ma'am, if they have a milder types of juvenile idiopathic arthritis, then we just follow up the patients. But if they have a moderate to severe kind of juvenile idiopathic arthritis, we treat the patient and if they have a milder form, we screen them till 12 years of age, ma'am. And
Actually, after 16 or 18, they do very well. So if you can postpone the surgery, it is better you postpone till 16 to 18. Okay, very good. Thank you.
Thank you, ma'am. Now I would like to invite Dr. Mayur sir for the questions.
Excellent presentation, team. So I would just want to know which, according to you, is the drug of choice for these patients? GIA-related uveitis, which would be the drug of choice?
so immunosuppressants such as methotrexate and infliximab, adalimumab.
Okay.
They will be the treatment of choice because they require long-term treatment, and so
And
it
if
will
you
be the
were to,
better choice as
yeah, if you were to start off with one drug, one of these three in an Indian setting, which one would you use?
so adalimumab.
Okay, probably one could start off with methotrexate and then move on to adalimumab. That would depend on the rheumatologist also. Another question that I would like to ask you is that in your presentation, you spoke of an entity called ERA, enthesitis-related arthritis.
Yes, sir.
Yeah. So, do you know if there is an entity called juvenile spondyloarthropathy? Is that entity the same as juvenile idiopathic arthritis, or is it different? Is the presentation same or different?
So it is different, sir.
How is it different?
Sir,
You're
sir,
right.
in enthesitis, there will be that part that is involving are the tendons and the ligaments around the joints. There will be inflammation of these part.
As far as the eye is concerned,
As far as the eye is concerned, sir, the other the enthesitis related juvenile idiopathic arthritis is a non-granulomatous one.
so like I'll answer the question for you. JIA, typically you say it is a uveitis in a silent eye,
Yes,
right?
sir. Yes, sir.
In JSPA, you will have the acute inflammation. It is in these patients that HLA-B27 is more likely to be positive, and these will present with redness, pain, watering, decrease of vision. So ERA is a subtype of JSPA. JSPA is a form of JIA. It is important to know this because when you have HLA-B27 positive older male person, then your screening can be a little relaxed. But in JIA, the screening can't be relaxed because they will come as uveitis in a white eye. Okay.
Yes, sir.
Very good presentation and excellent that you finished it exactly on time. Thank you.
Thank you, sir.
Thanks, Sahil.
Thank you. Thank you, sir. And I would like to invite Dr. Tinku ma'am for the question answer.
Yeah, so I'll echo that same sentiment. Excellent, very comprehensive and complete presentation and very well timed. So congratulations to you. So my question to you is if you could just re-enumerate and recount the risk factors that a patient with JIA would have, risk factors for developing uveitis. Which are the patients who would you be at a high risk of developing uveitis, these JIA?
Ma'am, the ANA positivity, girls are at a higher risk, younger age of presentation, and ma'am, especially the joints, if it is of oligoarticular type, less than 4 joints are there, then these are the risk factors for juvenile idiopathic arthritis, ma'am.
Very nice. And as Dr. Mayur said, the drug that we commonly give in these patients is methotrexate. So how would you follow up these patients? What are the investigations that you would advise these patients who are on methotrexate? Any idea? It's a very commonly used immunosuppressives, and I think we all should be.
Yes, ma'am.
What are the common side effects that you would look for and you would advise the patients these investigations?
Ma'am, if we are giving methotrexate, then we should we should ask for folic. We should look for folic acid levels, since it can suppress the level of folic acid in the body, and Rest I'm not sure.
You look at the hemogram to see for a decrease in the platelet counts, and you do a liver function test every month initially, and then you can do it maybe every 2 to 3 months. So these two tests are very important. Also, my third question, a patient generally have high pressure, these patients, but there could be a situation where a child comes to you with a hypotony. So what do you think is the cause of that hypotony? Why would a patient develop hypotony? It's a very common
Ma'am,
presentation.
is it because of the inflammation? Since the inflammation is very severe in juvenile idiopathic arthritis, it can lead to ciliary body shutdown, and that can present to hypotony.
Excellent. Yes. So ciliary body atrophy, ciliary body membranes, and you can do a UBM. You can sometimes see these ciliary membranes on the ciliary body. Excellent. Thank you.
Thank you, ma'am.
Great. Thank you, ma'am. Lastly, I would like to invite Dr. Somaya Mandal, sir, for the question.
First of all, congratulations for your very neat and clean presentation. I am very much fond of this less crowded slides, and I will always tell my students that one slide should not contain more than 4 or 5 lines. And you have just done that perfectly. And completing on time is a good quality. When you will be presenting on a bigger platform, it is a very good quality too. So congratulations for that. My question to you is, what are the causes of vision loss in this patient? What are the common causes of vision loss?
Because of the complication, the band-shaped keratopathy, cataract, they may develop glaucoma also, sir. And in the later stages, because of the chronic inflammation, the patient may develop squint or amblyopia. So that are the causes for the low vision in these children.
And during a cataract surgery in this patient, what are the factors you should look after pre-operatively or intraoperatively or post-operatively to take care of this child?
The most important is the inflammation one. We look for the inflammation. First, we should control the inflammation. Then only we can proceed for the cataract surgery. That we should look for pre-op also and post-op also.
Or how long the patient should be inflammation-free before cataract surgery?
The 3 months.
3 months, right. Okay. Thank you. Thank you so much.
Thank you, sir.
Thank you. Thank you, judges, and thank you, team. Now I would like to invite the next team, which is the site squad. Please start with your.
Sahil, we can take
We
the
have their
mentor.
mentor.
Sorry, yes. Sorry for missing. We have Dr. Unnati Sharma, ma'am, as the mentor of this team, 2020 Visionaries. I would request your comments, ma'am, and motivation.
Congratulations to the team for the excellent presentation and summarizing this topic in 5 minutes. I'm very thankful to the judges for providing the practical tips in managing the cases, and I appreciate the efforts of UC for providing the platform to these residents. Thank you.
Thank you for the kind words, ma'am. Now we will be moving on to the fourth team, that is the site squad. Please start with your presentation.
Am I audible, sir?
Yes, please start.
So our top,
Your audio is breaking up.
Your audio is break. Yeah, you need. Yeah.
Our topic for presentation is you get this? It's,
Your audio is breaking up, Dr.
am I audible,
Anjita.
sir?
Yeah. Yeah. Go ahead.
No.
I think you need to log out and then log in.
So I think maybe you just maybe approach a good network. Till then we can, Dr. Upal, can we move on to the first next team? First, you just sort out your audio issues.
1 second. Sahil, 1 second.
Yeah.
Yeah, Anjita, just speak
Anjita.
once. Yeah.
Now it's audible, na?
Yes, yes, now it's fine. Yeah, yeah. Ritu, can we have the timer, please?
Yes. Please begin.
You're going to start the presentation.
A topic is approach to acute uveitis. So, uveitis is caused by of diverse etiologies.
The audio is still bad. I think in the interest of time, Dr. Anjita, just stop sharing your screen. We'll move on to the other team. You need to log in again. Okay, and then we'll take yours. Okay.
Yeah. So we'll move down to the 5th team, that is the Arlt triangle. Please, Dr. Start sharing your screen and start the presentation. Then we'll again side squad. Till then you sort out your audio issues, maybe some network issues over there. So just sort it out. We'll take up next.
So judges, please note this is the 5th team in your Excel. Yeah.
Team
Arlt
Arlt triangle.
Yeah.
You may start.
So good evening, everyone. Am I audible?
Yes, you are.
Thank you so much. So we'll be talking about scleritis today. First, let us look at the anatomy of the sclera, the outer coats. So now here we have the conjunctiva, below which we have the Tenon's capsule, and then we have the episclera. It is of importance to note that there are 3 vascular plexus that we need to remember here. We have the conjunctival vessels, the superficial and the deep episcleral vessels as well. And topical phenylephrine has 2 concentrations which are important, 2.5% and 10%. 2.5% will blanch the conjunctival plexus, whereas 10% will blanch the superficial episcleral plexus, whereas the deep episcleral plexus remains unaffected by phenylephrine. Now, to differentiate between the episcleritis and scleritis, it is important to know that episcleritis involves a superficial plexus and scleritis involves a deep plexus. So the lesions of episcleritis are reddish, whereas they are violaceous in scleritis. Episcleritis is usually asymptomatic and idiopathic and often requires no treatment at all, whereas scleritis is very painful, has systemic associations, and almost always requires treatment. Watson and Hyre gave a classification of scleritis in which they divided scleritis into anterior and posterior. Anterior was further divided into diffuse nodular necrotizing, and necrotizing was further divided into with inflammation and without inflammation. Let's talk about the pain of scleritis. It is very severe, typically wakes the patient up at night and increases upon extraocular movements because of the muscular attachments to the sclera. It can also radiate to the rest of the face. Talking about diffuse anterior scleritis, this is a painful diffuse vascular congestion and dilation of vessels where recurrences are common. The average duration of the disease is about 6 years and the recurrences reduce in frequency down the line. Nodular anterior scleritis is even more painful. It has a scleral nodule usually within the interpalpebral fissure and it's immobile compared to the nodular episcleritis from which it has to be differentiated. This is often associated with a previous attack of herpes zoster ophthalmicus. Necrotizing scleritis is very aggressive, has a later age of onset, and is bilateral in nearly 60% cases. It's often associated with systemic diseases and requires systemic immunotherapy. It has different types like vaso-occlusive and granulomatous, and some special types as well, such as surgically induced necrotizing scleritis, which starts at the site of surgery, usually within 3 weeks, and extends outwards in a sectoral fashion. Scleromalacia perforans is another type in which there is necrotizing scleritis without inflammation. And because there is no inflammation, it is not very painful. It's usually seen in elderly women with long-standing rheumatoid arthritis. Can perforate with trivial trauma. Posterior scleritis refers to scleritis involving the region posterior to the insertion of the muscular recti. It is painful, but the pain may not always correspond to the severity. Rather, it is corresponding to the associated myositis. Bilateral in 35% cases, and the signs include choroidal folds as seen here, disc edema, and sometimes even a choroidal mass or exudative RD. The ultrasound scan shows the classical T sign, whereas the optic nerve is seen here, and fluid in the T subtenon space causes the arms of the T. And systemic associations include rheumatoid arthritis, which is the most important, and granulomatous with polyangiitis, relapsing polychondritis, PAN, and SLE. Infectious scleritis also deserves note, although it is very less common compared to immune scleritis. It has a variety of causes and it can be exogenous or endogenous. The complications of scleritis include keratitis, which may be peripheral ulcerative keratitis, stromal keratitis, or sclerosing keratitis, can also result in uveitis and acid reactions, can result in severe thinning and even perforation, and sometimes it can lead to increase in IOP leading to glaucoma or decrease in IOP leading to hypotony. These are the investigations that are usually required, including the routine and systemic workup. The management includes, it will depend on whether it is an immune-related scleritis, which needs a holistic approach, including discussion with a rheumatologist, wherein we'll start the patient on topical or periocular steroids, oral or intravenous NSAID steroids, and steroid sparing immunomodulators and biologics like TNF-alpha inhibitors. If it is infectious, then we would target the infection using antimicrobial agents. Sometimes we might need to do surgery like scleral debridement or using a scleral patch graft. Thank you so much.
Super. Before time. Okay, so from first team to next team, everybody is improving. So now for the question answer session, I would like to invite Dr. Mayur sir to start with the questions.
Thank you, Sahil. Excellent presentation. Just one question to you. In terms of pain, how is posterior scleritis different? Is there a specific timing to the pain, or is there a specific position that the patient is in that the pain occurs? Do you know about this?
Usually it happens at night, and it is associated with the horizontal level position because the edema settles more in the tissues and results in even more pain.
Excellent, excellent. Thank you. Sahil, you can move ahead.
Yeah, great. Now I would like to invite Dr. Ratnam madam for the questions.
In Indian farmers, what is the common cause of scleritis? A farmer from a village comes with a scleritis. What is your first differential diagnosis?
Could be an infectious scleritis, ma'am, or it could be not very sure, but
you are right. It is most of the time in farmers, agricultural injuries are common. Injury with vegetable matter is more associated with fungal infectious scleritis. Even though books mention infectious scleritis is rare, it is not rare in India, especially from lower socioeconomic farmers. Fungus is very common. We have to be very, very cautious before we think of granulomatosis and angiomatosis. Okay, thank you. Thank you so much.
Thank you, ma'am, for a beautiful insight. I would like to invite now Dr. Tinku, ma'am, for the question answers.
Okay. So when you see a patient with scleritis, you dilate the patient and you see the posterior segment, right? Any case of any patient of scleritis, you're supposed to see the fundus. Now, in a patient of posterior scleritis, what would be your findings on the fundus examination?
It's mentioned in the presentation as well. We can see disc edema sometimes, we can see choroidal folds, we can see exudative retinal detachments, or sometimes even what looks like a choroidal collection of fluid.
And when you do an OCT, what would you see in these patients?
When we do an OCT, then we'll be able to, if there's any fluid collection, then we'll be able to see that in the
what is the typical picture described on OCT in posterior scleritis?
We can have
Because
NSD.
we do an OCT, you know, yes. What kind of NSD?
Kind of NSDs, usually pinpoint NSDs are present.
What about fluorescein angiography? What would you see on that?
On fluorescein angiography, we can see pinpoint leakage, hyperfluorescence. And on ICGA, then we'll be able to see some early diffuse hyperfluorescence followed by a late pinpoint hyperfluorescence.
Pinpoint hyperfluorescence, which increases in the late phase. And on the OCT, you can see loculated, serous detachments. And on a B scan, apart from the T sign, what else would you look for in a case of posterior? What else would you see?
In cases of posterior scleritis, if other than the inflammation leading to T sign, if there is any choroidal detachment also or any choroidal elevation, then that would be visible. If there's any mass associated along with the sometimes posterior nodular scleritis can even mimic choroidal masses or they might coexist together. So we can look for that as well. And
you can actually see a scleral thickening in most of the cases, which is more common than a T sign. T sign would not be present in all the cases. Okay, thank you. Thank you.
Thank you, ma'am. I would like to invite Dr. Vishali, ma'am, for the questions.
Thank you. Very well prepared, team. I have a question which might be slightly difficult at your level, but try. You just discussed with Tinku, like it could be hyperfluorescent, punctate hyperfluorescence, and neurosensory detachment. How would you differentiate it from VKH?
one thing is the clinical presentation of VKH that itself is very different. It is bilateral and it has a completely granulomatous picture, and there also we can see pinpoint leakages.
No, that's at the very late stage, the granulomatous picture. You know, in the early forms, you may just have pinpoint hyperfluorescence and the pooling of the dye. So the way to differentiate is one, history of pain, like myosid will be against VKH. Second, you look at the disc hyperfluorescence on fluorescein angiography in this eye as well as the opposite eye. VKH is invariably bilateral. Third is you look at the choroidal thickness. Like in sclera, you will have scleral thickness, but if you have diffuse choroidal thickening, that will be in favor of VKH. Good. Thank you.
Nice. Thank you, ma'am, for nice learning points for us also. Lastly, I would like to invite Dr. Somaya Mandal, sir, for the question answers.
So you have also presented nicely and on time. Congratulations for that. So if a patient presented with a unilateral scleritis, so what are the history you will want to take in this patient according to in respect to the previous surgery in that eye? What may be the surgeries that predisposes to scleritis lateral?
So pretty much any surgery can lead to surgery-induced necrotizing scleritis, but commonly seen once in pterygium surgeries and trab surgeries and even strabismus surgeries. And especially in these surgeries, if mitomycin C is used or if there's a prior history of radiation for any reason, then that increases the risk of SINs later.
So mitomycin C is the agent which can lead to the thinning of the sclera. So usually the patient presents with unilateral scleritis. If a patient presents with bilateral scleritis, so what are the systemic thing you will be asking for in bilateral scleritis?
Bilateral scleritis, it's more likely to have an underlying systemic disorder. So we would want to investigate them thoroughly for all rheumatological diseases, starting with rheumatoid arthritis and moving on to other vasculitic disorders. We'd send an ANA panel, ANCA panel, serum A's, and if we're suspecting something on like TB or Lyme's, then we'll get that workup also done.
Okay. Thank you. Thank you so much.
Thank you. Amazing. So that this ends up with this team, and now we would like to invite the team 4.
We can have the mentor.
Yeah. Okay.
Yeah.
Yes.
Is here.
Sorry. We have Dr. Dr. Amber, ma'am, for the as a mentor. So I would like to ask Dr. Amber to please give some insightful words for the team.
Good afternoon, everyone. I would like to congratulate the team for a very concise and to the point presentation. And I would like to thank YOSI for organizing such learning practices and learning platforms, teaching platforms for the young ophthalmologist. I would also like to thank the esteemed judges for sharing the pearls of wisdom and practical knowledge for their day-to-day life for us learning ophthalmologists. Thank you so much.
Thank you for the kind words, sir. So now we'll move up back to the team 4, which is the site squad. I think they are now ready with their presentation. So judges, this will be the team number 4 for the marking purpose. Site squad.
Am I audible now, sir?
Yes, perfect.
Yes.
Yes.
So a very good afternoon to all. So our topic is approach to acute uveitis. So uveitis is caused by disorders of diverse etiologies, including infectious and non-infectious causes. And the clinical signs are less specific and on several occasions, uveitis represents diseases that are developing elsewhere in the body, and ocular signs may be the first evidence of such systemic diseases. So coming to the approach to a patient with acute uveitis, it includes the uveitis workup starts with an elaborate history taking. It includes the onset and progression of symptoms, course, and treatment received, the corticosteroids therapy, the past ocular history of recurrent attacks of uveitis and previous response to treatment, and a detailed systemic history, along with a social history for pet, dietary history, sexual, and drug history should be obtained in detail. So over 70% of the diagnosis can be made on the basis of detailed medical history and thorough clinical workup alone. So according to the Sun classification, uveitis was divided into anterior, intermediate, posterior, and pan-uveitis according to their primary site of inflammation. And various descriptors for defining the onset, duration, and course of uveitis have been proposed in the Sun classification. And the etiologies of uveitis can be varying. It can be associated with systemic diseases like HLA-B27 associated, Behçet's disease, etc. It can occur after a systemic infection like leptospirosis, tuberculosis, etc. And the ocular infections like endogenous endophthalmitis, toxoplasmosis, and uveitis like birdshot, retinochoroiditis, Fuchs uveitic syndrome, etc. And it can be drug-induced. And finally, do not forget the masquerade. On ocular examination, the corneal endothelium shows keratic precipitates. It can be fine capes as seen in herpetic eye disease and in other non-granulomatous conditions. Mutton fat or large capes can be seen in granulomatous uveitis, and stellate or star-shaped capes are seen in Fuchs heterochromic iridocyclitis, and old capes are seen pigmented mainly. And in fading of the cells and flare in the anterior chamber, the cells are there counted using a slit lamp with a beam of 1 into 1 mm slit and graded according to the Sun working group grading scheme. And flare is also graded according to the scheme proposed by the Sun classification. And the presence or absence of a hypopyon or hyphema should be recorded separately while documenting a case of uveitis, and also check for the IOP. On the iris, look for nodules. Those seen in the pupillary borders are known as the Copley nodules, and nodules on the iris surface is called as the Busaka's nodule. And the posterior subcapsular cataract is a common complication after long-standing uveitis as well as chronic corticosteroid therapy. And the iris atrophy is a characteristic feature of herpetic uveitis. For classifying vitreous haze, the Sun classification has adopted the National Eye Institute system for grading the vitreous haze. And the optic disc should be carefully examined for disc edema or hyperemia. The examination of the retinal vasculature for vasculitis and vascular sheathing should be done. And also, it is important to determine whether the retinal veins, retinal arteries, or both are affected, as it can help in differential diagnosis of the uveitic entity. And a detailed history of various systemic diseases should be taken. After ulceration can be seen in patients with Behçet's disease. An elaborate history of joint pain should be taken. Rashes can be seen in various conditions with uveitis as an SLE. Alopecia and poliosis can be seen in patients with VKH. And on investigations, the ocular investigations include FFA, ICG, fundus autofluorescence, ultrasonography, and optical coherence tomography. And systemic investigations should be tailor-made and treated accordingly. And the treatment part, for anterior uveitis, topical steroids along with cycloplegic are given, and the systemic steroids and immunosuppressive agents are given if not responding to it. And for the management of intermediate uveitis, we follow the Kaplan regimen. Step 1 is periocular steroids. Step 2 is oral steroids. Then step 3 is systemic immunomodulatory therapy. And finally, indirect laser photocoagulation or cryotherapy is done. And the treatment for management of postnatal and pan uveitis for infectious specific therapy along with the steroids are given, and for non-infectious steroids remain the mainstay of therapy. And finally, to conclude, take uveitis-oriented history, complete eye examination, identify the anatomic location and extent of the primary uveitis, and get an overall systemic evaluation. And order for a tailored investigations and treat accordingly. Thank you.
Superb. One more. Very good. So now, yeah, you can stop sharing the slide screen. For this team, now I would like to start inviting judges. I would like to invite first Dr. Tinku ma'am for the question answers to the team side squad.
So yeah, excellent presentation. Again, it was very well timed and you put together all the information very concisely and comprehensively. So congratulations for that. So my question to you is that in our country, the most common cause of uveitis that we first think of, be it posterior or anterior, is tuberculosis. So what are the tests that you would advise to such a patient when you see a patient who you suspect would have tuberculosis?
Okay, now. After all basic systemic investigations like ESR, PRP, all that, we order for specific investigations like Manto tests, then using purified protein derivative, then a test like IGRA can be done. Then we order for a chest X-ray.
So yes, so chest X-ray, I would say in today's day and age, I think if we should be advising a CT scan of the chest, on most specifically a contrast enhanced CT. So that is a CT scan. Many times the X-ray will not pick up all the information. It will not pick up the lymph nodes, the mediastinal lymph nodes. So either a high resolution CT scan or more or better is to order a contrast enhanced CT scan along with your Montus test and your quantiferon gold test. Okay. And the other question is that you see a patient with pan uveitis. Okay. What would come to your mind? What are the most common conditions in India, in our country, which cause a pan uveitis?
Okay, a pan, bacterial, like infection, can be infectious or non-infectious. So infectious can be tuberculosis, syphilis, etc., or herpes virus, cytomegalovirus, and certain fungal infections and parasitic infections like
the most common. If we could enumerate 1, 2, 3, the most common conditions which cause pan uveitis in the Indian. So first you said was tuberculosis. Very nice. Yes.
Yes, no.
That would be the most common.
Then non-inflammatory, then non-infectious conditions like sarcoidosis.
Yes. Sarcoid and VKH. VKH is another very common condition that we now see in our country, which causes a pan uveitis. Okay, apart from all the other list, syphilis again now is making a resurgence, but it's not so common. We have started seeing syphilis cases, but it's not very common. So I would say tuberculosis and VKH are very common conditions which cause a pan uveitis. Apart from that, sarcoidosis, of course. Okay, thank you. Those were my questions.
Thank you, ma'am. I would like to now invite Dr. Vishali ma'am for the questions.
Thank you for a very comprehensive presentation. My question again, you're sitting in a clinic and the patient comes with granulomatous anterior uveitis. There are mutton fat keratic precipitate, few nodules on the iris, 1+ flare cell posterior synecdoche. Fundus normal. What will you do?
For granulomatous uveitis, it is mostly for Hello.
Yeah, I can hear you.
Okay, first we have to do the basic investigations. like TBP, ESR, should be done. Then
TB, PCR.
no,
You said TB, PCR?
no, ma'am. For
Okay, I'll help you. So if you see a granulomatous uveitis, you know, in common, there are three things which can cause it. TB,
hello, ma'am.
sarcoma.
Okay, ma'am.
Go on, go on.
For granulomatous uveitis, it can be due to a chronic cause. Insidious onset and a chronic cause.
Insidious onset.
Then you can find like iris nodules and medium to large taperies.
I think, Dr. Anjita, you missed ma'am's question. Ma'am, I think you can just proceed with the answer to the question that you asked.
Okay. So if you see granulomatous uveitis, there are three main causes which can cause it in our setup. TB, sarcoid, are sometimes viral, which we mostly misdiagnose or we miss. So first of all, look at the IOP. If the IOP is high and there are cells in the interior chamber, it's more likely to be viral.
Viral.
Okay. Look at the posterior synecdoche. If posterior synecdoche are absent, more likely to be viral. And of course, then you look at the corneal sensation and iris illumination. Now, if those things are not there and you are not suspecting viral, then it could be TB or sarcoid. So what investigations would you ask from the patient?
Okay, ma'am. For sarcoidosis, we ask for serum A, then serum calcium for blood investigations. Then we ask for CT chest. Then also we can order for a gallium scan for to rule out sarcoidosis.
Not really. You will not straight away jump the patient's first visit and you give the gallium and the calcium. No, you just get a Montius test done. If the Montius is negative, which it should not be in our population, that itself would be an indicator towards possible sarcoidosis. If Montius is 10 or more, that indicates TB. When you do see CT chest, what would you look for?
Look for hilar lymph nodes. Then
For sarcoid, and what would
for
you look
for
for in
TB,
TB? What would you look for?
look for cavities, lung cavities or granulomas.
So that is another mistake. TB does not present actively in the lungs as well as in the eye. And the CORD study has shown it convincingly that more than 91% of the patients with ocular TB will not have any pulmonary disease. So when we do CT chest, we are not looking at the pulmonary disease. We are looking at the evidence of exposure, which is Ghon's focus. So you are just looking at some kind of calcified lymph nodes, nothing more than that. Okay? And you don't order ACE without asking the history of ACE inhibitors and steroid exposure because it will be false in both the cases. And I don't think anybody does calciums or galliums these days because if there is hilar nodes, you just do EBUS and transbronchial lung biopsy. Okay? Thank you.
Thank you. Thank you so much, ma'am. I would like to invite Dr. Ratinam, ma'am, for the question answers.
Yes. First question is, your topic is acute uveitis. Am I right?
Yes, madam.
But you didn't concentrate on acute uveitis. You were concentrating more on sun nomenclature. So your focus should be always to the topic that is allotted to you. Okay? So that is an instruction. One question, what is the commonest acute anterior uveitis in our population? Commonest acute posterior uveitis. or pan-uveitis for that matter. One anterior uveitis, one pan-uveitis, acute.
Okay. Infectious uveitis, HLA-B27 associated is the most common.
Good.
And
acute
posterior
pan-uveitis. Acute
tubercular
pan-uveitis.
TB and sarcoidosis can
No,
take
no,
in
both are
span.
granulomatous chronic insidious. Acute retinal necrosis. The name itself has acute retinal necrosis. Okay, thank you.
Thank you so much. I would like to invite Dr. Somaya sir for the questions.
So I think you are nervous a little bit. Don't get nervous. It is not an official these things are made just to make you some exposure and to get you prepared for these bigger stages. So don't get nervous. So you already asked all the questions. So my last question is, there are two things. One is acute anterior uveitis, and one thing is posterior uveitis with spillover anterior uveitis. So can you differentiate between these two? Because in both these cases, you will get cells in the anterior chambers.
Okay, sir. In acute uveitis, you will get more of anterior segment changes like cells, flare, then KPs, along with vitreous haze. But for posterior uveitis, you can see like any retinitis or choroiditis patch along with vitreous haze. And the anterior segment changes will be minimal in case of a posterior uveitis.
Okay, so that's why we are asking everyone to dilate all the patients with uveitis to look for any posterior pathology also, because anterior uveitis which are coming to general ophthalmologist, they will just write some steroids and send back the patients. Don't do like this. Always dilate the patient and see for any posterior pathology. And one common mistake residents do is they write a combination of antibiotic and steroids, and they taper the combination with 64321. Don't do like this, because antibiotic cannot be tapered to less than 4, or it will lead to antibiotic resistance. So if you want to start antibiotic and steroid, most of the time it will not require, only steroid is required, only Predford or something. So prednisolone you can taper properly, 65431, but antibiotic moxifloxacin you cannot taper less than 4. Okay, you cannot taper like Catalogs DM, you cannot taper 65431. So that is a common mistake residents will make. Otherwise, a fantastic presentation. Thank you.
Thank you, sir. And I would like to invite Dr. Mayur sir for the questions.
Yeah, good presentation, Anjita, and a very simple question to end is I want to know what is the drug of choice for an acute anterior uveitis, which is the eye drop of choice?
Sir, first, after ruling out infectious, you can start. Systemic steroids are the mainstay of treatment for any uveitis.
For an acute anterior uveitis, which is the eye drop of choice?
Prednisolone, sir. Prednisolone acetate 1%.
Yes. Okay. Good. Good. Thanks.
Very precise, very precise, Toby. Okay, so that brings us now. I would like to invite their mentor, Dr. Risha KR, for your kind words and motivation to the team of Site Squad.
You're on mute.
Yeah, good afternoon. I congratulate YOSI for organizing such a wonderful meeting, and I wish my team members good luck. Thank you.
Thank you so much, ma'am. So now this brings us to the last team and their presentation, the site seekers. So site seekers, please come up with your presentation and share your screen.
Yes, sir.
Half your
Again, you're
screen.
Your screen is again getting cut. Can you share it again?
Yes, ma'am.
Sahil, do you have the presentation?
Yes. I have the backup. Let them share once more. Otherwise, I'll
Yeah,
stop.
sure. This is fine. Yeah, this is fine now. Okay. Yes. Yeah. Imagine you wake up one day and you have blurry vision. But what if I tell you this blurry vision is a sign of something more sinister? Good afternoon, everyone. This is Team Sight Seekers, and let's walk through the ocular manifestations of tuberculosis. What comes to your mind when you think of a lean cachexic patient coughing his lungs out? The most probable thing is tuberculosis. But why does it not strike you when you see a painful dacrocystitis with a discharging sinus in OPD, or a young child with proptosis and lid swelling? Ocular tuberculosis is an infection by the gram-positive bacilli Mycobacterium tuberculosis that can affect all ocular structures, right from the eyelid to the optic nerve. The tissue damage is not only a direct consequence of infection, but it is also due to hypersensitivity reaction and non-resolving inflammation. Tubercular uveitis, and more commonly posterior uveitis, is a prevalent manifestation of tuberculosis as the bacteria thrives in the richly vascular choroid. This versatile disease can present in various forms, ranging from a subtle granulomatous anterior uveitis to a severe panophthalmitis. The clinical presentation can be diverse, featuring multifocal, scattered chorioretinal lesions or serpiginous-like choroiditis, which is also associated with vitritis, or a more challenging form of retinal vasculitis, diagnosing all of which requires a meticulous process of exclusion. In the Indian setting, another visually debilitating manifestation of ocular tuberculosis that needs to be discussed is Eales disease, which is an idiopathic occlusive perivasculitis affecting peripheral retina and leading to retinal non-perfusion, neovascularization, and recurrent VH. The classic presentation is a young male walking into our OPD with a sudden onset of unilateral blurring of vision and floaters. Once the diagnosis has been established, corticosteroids remains the mainstay of treatment in this active vasculitis that mainly affects the veins. When neovascularization has occurred, peripheral scattered photocoagulation is important, and persistent vitreous hemorrhage requires a vitrectomy. Now, the criteria for presumed tubercular uveitis is choroidal granulomas, which is in the form of either a tuberculoma, a solitary tuberculoma, or choroid tubercles, broad base posterior synechia, retinal vasculitis with or without choroiditis, or serpiginous-like choroiditis with a positive test, that is a positive PPD, quantiferon gold, which we will discuss further, or a chest X-ray or CT scan. As we move along the diagnostic journey, one of the most important things that we need to remember is that ocular tuberculosis is a clinical diagnosis, and history taking is very important, in which the patient's profile, the ethnicity, age, history of contact, all helps us reach a diagnosis. A positive tuberculin skin test, or PPD, is considered important in the sphere of ocular tuberculosis. However, a negative test does not rule out TB. More importantly, the interferon gamma release assays like commercially available quantiferon TB Gold are much more sensitive in ocular tuberculosis, and a combination of PPD and quantiferon TB Gold is used for establishing a diagnosis. Isolation of Mycobacterium tuberculosis by culture remains the cornerstone. However, that is not always possible when we talk about ocular tuberculosis due to the possibacillary nature of MTB. If there is an absence of TB in the specimen, this does not rule out the diagnosis. And in this circumstance, the molecular diagnostic test CB-NAT can come into picture, where the detection in the sample, such as for an aqueous humor or a vitreous humor, can be used to establish a diagnosis as well as to monitor the treatment response. The treatment here remains multidisciplinary with the involvement of both the ophthalmologist as well as the pulmonologist, and ATT remains the treatment of choice. It helps in reducing inflammation as well as preventing recurrences. There is a 4-drug regimen that has to be followed. Now, the role of steroids here is controversial But in case of bilateral severe disease, it helps in reducing the inflammation. ATT comes with its own set of cons, where ATT-induced optic neuropathy is very severe, and hence these patients require regular monitoring. Here we highlight the future course of the disease, where refining diagnostic tools, disease mechanisms, and standard protocols are required to maintain the treatment. Thank you.
Thank you so much. And okay, very good, on time. So now for this team, we will start inviting first Dr. Vishali ma'am for the question answer session.
I think very well presented, very clear. My question to you, when will you treat a patient with anterior uveitis with ATT?
Ma'am, since ocular tuberculosis remains a diagnosis, clinical diagnosis, in case if the clinical symptoms match of that of TB, even if there is a negative PPD, we can take an aqua sample biopsy for a PCR, and or if there is a presumed tuberculin test, then we can start with ATT treatment.
Okay. Now, suppose you have a patient who has acute anterior uveitis, fibrin in the anterior chamber, history of low backache, and positive TB gold as well as positive Monteus. How will you treat this patient?
Ma'am, we will initiate in this kind of a scenario. We should initiate anti-tubercular treatment as soon as possible. If the inflammation is a consultation with rheumatology is very important. And if the inflammation is acute and very severe, then a course of steroid is also required. Now, this steroid can be in the form of topical corticosteroids, and if it is able to control the inflammation, well and good. If not, then we can go for oral steroids as well.
Yeah, so that is the bottom line. When you have a clinical phenotype, which is not suggestive of TB, the lab tests do not matter, okay? The scenario I gave you was angst associated acute anterior uveitis. So you have acute anterior uveitis, low backache, fibrin. So that kind of a scenario, you should not even think of TB as a possibility, because you have to know the pre-test probability of all the tests. If your clinical presentation is such that the probability of the TB test is going to be high, it means if those tests come positive, then you treat. But if your clinical phenotype is such that you are not suspecting TB, please do not start giving ATT, because you yourself said that the risk of optic neuropathy is very high, you know?
Yes,
So we do have this beautiful app called COTS Calculator, in which you can enter the scenarios and you can enter the test, and it gives you a value that how many experts will actually agree on starting ATT. And this is to avoid the over treatment with anti-TB drugs. Thank you.
Thank you, ma'am.
Thank you, ma'am. Please stop sharing the screen, the team.
Yes.
Yeah. Okay. So next, I would like to invite Dr. Ratinam ma'am for the question answers.
Yes, your presentation was very good. Clarity was very good. The only caution, as Dr. Vishali Gupta mentioned, her phenotype was very clear. Acute anterior uveitis with low back pain. You should always remember HLA-B27 or ankylosing spondylitis associated uveitis. So the phenotypic recognition is very important, because TB mimic all types.
Yes,
we should not be biased with TB alone.
Yes,
But
ma'am.
your presentation was very good. And what is the TB, anti-TB regimen now government is following?
Ma'am, here we usually give the 4-drug regimen for the first 2 months.
How many months?
The treatment is typically from 6 to 12 months, 6 to 9 months. We start with the 4 drugs: isoniazid, rifampicin, ethambutol, and pyrazinamide. After 2 months, pyrazinamide is stopped, and the rest of the 3 drugs are continued.
Wonderful. Wonderful. Thank you.
Thank you.
Okay. So next, I would like to invite Dr. Tinku ma'am for the questions.
Yeah, so first of all, I'd like to applaud you for your presentation. You very comprehensively showed all the presentations, and you very nicely highlighted that tubercular diagnosis is often a presumptive diagnosis. We don't always have a diagnosis from the tests. And also you highlighted the risk of optic neuropathy on patients with ATT. So excellent. So you also mentioned serpiginous-like choroiditis in your presentation. So could you tell me how would you differentiate a serpiginous-like choroiditis from a serpiginous choroiditis, a chronic serpiginous choroiditis?
Ma'am, a serpiginous-like choroiditis is multifocal, scattered, usually involving the peripheral retina, and it is also associated with vitritis. A serpiginous choroiditis will more originate from the peripapillary region and then extend further. And vitritis is more or less not seen in these cases. And it will be more focal involvement of the retina will be seen.
Also unilateral in a
And unilateral presentation.
Excellent, very nice.
We must compliment your mentor. Very well done.
Excellent. She's answering the questions also superbly.
Thank you, ma'am.
So have you heard of something called a paradoxical reaction in tuberculosis? Have you heard of that?
Ma'am, I
Okay,
am not very sure about
So
that.
when you start a patient on ATT, sometimes the lesions might worsen
Worsen,
initially. It's a rare presentation, but it does happen and we should be aware.
Okay.
So, but you still continue the patient on ATT. Sometimes you may need to add steroids. Also, you mentioned the risk of optic neuropathy on a patient. So how would you counsel a patient who's been started? You know, now the ethambutol is given for a much longer time. Earlier, it was given for 2 months. Now, throughout the course, ethambutol is given. So how would you counsel your patient, regarding the risk of what would you tell him to come back?
Ma'am, first of all, what is very important is that the pulmonologist or the ophthalmologist, both of them have to emphasize on the fact that the treatment is very important to stop the infection, and we have to take care of the vision as well. At every visit, the visual acuity should be assessed along with the color vision as well as the near vision. Baseline fundus photograph as well as OCT, RNFL, and everything has to be maintained. And when the patient visits at regular intervals, we have to repeat that. If there are any changes, we have to continue it. Then the patient has to be counseled that if there is any sudden onset of vision loss or if he's feeling that there is a gradual diminution of vision, he has to report to us as soon as possible, so that the toxicity is very dose dependent. So we can talk to the pulmonologist if the dose can be altered, or we can think of any alternative drugs that can be used so that the vision is not compromised. And in a lot of these patients, if we give them under a cover of steroids, also in our practice, in our setup, we have seen that it does have a protective mechanism, so we can take.
So it's not only loss of vision, sometimes it could just be a loss of contrast or the colors would appear washed out. So any change in visual perception, you have to counsel the patient that he should report immediately, because sometimes it could be a permanent loss of vision.
Yes, ma'am, because counseling is the most important thing, because the patient might discontinue the treatment when it comes to
Thank you.
Thank you, ma'am.
Very well fielded questions. Thank you.
Thank you.
Thank you so much. Now, next I invite Dr. Somaya sir for the questions.
So I think you have the most confident or most well-prepared presentation, in my opinion, of today's session.
Yes, sir.
Congratulations for that. So most of the questions are complete, and your content is also very good. So I have 2-3 questions, small questions. So if a patient of ATD comes to you with vision loss, so what electrophysiological test you will prescribe to this patient?
Sorry, sir, connection actually just bad. Can you please repeat the question, sir? I had some problem in the internet.
Sure. So electrophysiological test.
Electrophysiological test. Okay.
Which you want to prescribe in a case of ATD-induced neuropathy.
Okay. Sir, electrophysiological tests, we need to make sure that insulting agent or the insulting drug has to be stopped. And then the patient can be told to go for a VEP for assessing the optic nerve function. And based on that, we can take further.
Right. So do you know other drugs other than
We can go for ERG as well. And for the any retinal evoked potential, or what if there is any changes in that, because ethambutol toxicity is associated with it. There is I think a pattern electroretinography that is also done, but I'm not very confident about it.
So any other drug other than ethambutol that is?
So we very recently saw a patient who had linezolid induced toxicity as well, which is one of the off-label drugs that is used for treatment of ocular tuberculosis. And we've also seen it sometimes other drugs such as rifampicin and isoniazid can also cause this kind of toxicity.
Isoniazid can also cause.
Yes, sir.
So if a patient with Eales disease comes to you with in a vasculitis stage, how
Yes.
do you proceed in this case?
Sir, when a patient with Eales disease comes to us with an active vasculitis state, then apart from suggesting the investigations that are required, one of the things that active vasculitis requires is corticosteroid treatment. So oral corticosteroid has to be initiated in these patients immediately, so as to control the spread of the vasculitis as well as preventing recurrences. And the patient needs to have monitored blood sugar levels as well as other tests need to be there, so as to make sure that it is not causing any other systemic manifestations in this patient.
Oh, I think so. Okay.
So,
sure, sir. Okay, so
outline does that way. Okay, fine. Thank you.
Thank you so much,
yes,
sir.
thank you. So last, I would like to invite Dr. Mayur sir for the quick questions.
Yeah, excellent presentation. I echo with Dr. Mandal that your presentation and all the questions that have been asked by all the judges have been pretty comprehensive. It sums up the topic. Just one question. You can answer it in one word. What is the manifestation or the inflammatory manifestation of tuberculosis in the conjunctiva called?
Flectin or flectinular conjunctivitis.
Yes. Good.
Thank
Fine.
you, sir.
Yeah. Sahil, you can go.
Oh, thank you. Thank you for all the teams and the judges for the comprehensive coverage and the
Our mentors there.
Yes. Now
Dr.
we
Arun
have
Sharma, sir.
Dr. Arun Kumar Sharma sir as a mentor of as already we have received compliments about the mentorship also. So please, sir.
A lot of blessing to the team site Sekar, and congratulations to all the YOSI teams who are organizing such a wonderful things and good conversation and good discussion also here. So I will request you to in the future also do such kind of thing. Thank you.
Thank you so much, sir.
I'll request all the mentors who have joined today to encourage their other PGs also to, enroll for the future sessions of iROCK. So
Yeah, a part of everybody, every team is very good.
yes.
Everybody
I mean to say, sir,
good.
other PGs, as in other PGs from your medical college also can, more 3-4 PGs can participate in iROCK. So you can encourage them to participate.
Definitely, we will do that thing in the future.
Yes, sure. Thank you.
Okay, so with this seminar session coming up to the end, we have the next session. I'll just share the screen and continue with the remaining presentation.
So judges, this next round is, we've asked the teams to prepare 2-minute creative reels pertaining to UVEA. So that's how it is going to be. And over to you, Priya, for this thing. Yes.
Okay, so shall we start the next round? So can we have the first reel?
Yeah.
Okay, so before announcing, let me tell you one thing. In order to be on time, the comments will be invited by one judge for one reel, but marks to be given by everyone. Okay, so can we have the reel, please? So rules for round 2 is team member will collaborate to give a creative presentation in the form of reel, music, dance, etc. on the topic of interest. Mark should be 20 and theme is UVEA. Okay. So team 1, the Vogt trio, the reel is B.
यार ये रोज रोज कमर का दर्द लाइट क्यों इतनी चुभ रही है चश्मा लगा के भी सही नहीं दिख रहा अरे ये तो मेरी दोनों आंखें लाल हो गई गूगल करके देखता हूँ क्या हुआ है यार ये तो आई फ्लू लग रहा है 1-2 साल पहले भी तो हुआ था कौन सी ड्रॉप डाला था मैंने मॉक्सी, हाँ यही डाल के देख लेती, क्या पता सही हो जाए। मैम ये दोनों आंखों में बहुत दिनों से दर्द हो रहा है और धुंधला धुंधला भी दिख रखा है, पास का और दूर का। रेडनेस भी हो रही है, आप एक बार देख लीजिए।
आपको पहले कभी ये दिक्कत हुई है क्या?
हाँ 1-2 साल पहले हुआ था, पर वो ड्रॉप्स वगैरह डालने से सही हो गया था।
बाकी कोई शारीरिक बीमारी जैसे मुंह में छाले, जॉइंट पेन या पीठ में दर्द?
छाले वगैरह तो नहीं, लेकिन कमर में दर्द हो जाता है कभी ठीक से ना सो तो।
मुझे लगता है आपको आंखों की सूजन की बीमारी यानी यूवीआइटिस करके बीमारी है एंड काफ़ी बार कमर का दर्द भी इससे रिलेटेड होता है। तो मेरे हिसाब से आप ये सारी जांचें करवा के मुझे 1 हफ्ते में रिपोर्ट के साथ मिलिए एंड तब तक के लिए ये दवाई स्टार्ट करिए।
मैम आंखों में तो बहुत फ़र्क है, दर्द भी कम है, लाल भी कम है, दिख भी साफ रहा है पहले से, पर ये रिपोर्ट शायद मेरी पॉजिटिव आई है, आप एक बार देख लीजिए।
मेरा शक सही निकला, आपको शायद एंकालोजिंग स्पॉन्डाइलाइटिस नाम की बीमारी हो सकती है। इससे आंखों में बार बार सूजन आती है। आपको फौरन एक हड्डियों के डॉक्टर से मिलना है और इसका इलाज करवाना है। अगर बार बार आंखों की सूजन हुई तो आंखों की रोशनी भी जा सकती है और काला मोतियाबिंद, सफ़ेद मोतियाबिंद जैसी बीमारियां भी हो सकती है।
थैंक यू मैम, ना सिर्फ आपने इस बार मेरी आंखों को सही किया बल्कि आगे भी खराब होने से बचा लिया। मैं आज ही जाके हड्डियों के डॉक्टर से मिलता हूँ।
बढ़िया, और अभी आज से गूगल बाबा की
नहीं सुनेंगे।
So that's a very wonderful, informative and short, crisp, filmy-like reel. So I would like to invite Dr. Athina ma'am for comments.
Thank you for giving this case. One important flaw is patient says orthopedician and the doctor accepts. Actually, patient should be going to rheumatologist. That is the only correction. Otherwise, it is wonderful.
Yes, ma'am. Very nice.
Yeah.
Okay, so shall we proceed to the next reel? Okay, so the next reel is from the team Visionaries.
मेरी याद तेरे तो नहीं, पुतली फट गई है, ठीक है, तो इसकी सिलाई करनी पड़ेगी।
ऑपरेशन तो हो गया, अब मेरी आंख बच जाए तो मेरे सही रहे। डॉक्टर साहब मेरे इस आंख में दर्द बहुत ज्यादा होता है, आंख लाल लाल हो गई, पानी आता है डॉक्टर साहब।
कितने दिन से हो रहा है
ये डॉक्टर साहब? 2-3 दिन से हो रहा है, बहुत ज्यादा होने लगा, पहले होता था अब ज्यादा होता है।
आजकल वैसे भी इन्फेक्शन बहुत फैल रहा है, शायद इन्फेक्शन ही होगा, तो मैं दवाई लिख देता हूँ।
जी डॉक्टर साहब, आपने पिछली बार दवाई लिखी थी मैंने इस आंख के लिए, तो अभी तो सही हुई नहीं, उससे फर्क कोई फर्क नहीं पड़ रहा है।
थोड़ा सा इन्फेक्शन ही तो है यार, बताया तो था पहले। अब तुम दवाइयाँ लेते नहीं हो प्रॉपर टाइम पे, कैसे हुआ है? दोबारा लिख देता हूँ, मुझे और लेना, फिर से दोबारा डोज बढ़ा देता हूँ।
तुम्हारी रिपोर्ट देख के लग रहा है कि तुम्हारी इस आंख की चोट की वजह से अब जो असर है इस आंख की, वो इस आंख में भी सूजन, जो दूसरी आंख है जिसमें अब तुम्हें तकलीफ हो रही है, उसमें ये सूजन बढ़ गई है। ये इस आंख में चोट के कारण ऐसा कई बार दूसरी आंख में भी ये बीमारी फैल सकती है। तो इसके कारण ये एक वो ऑटो इम्यून डिजीज होती है कि इसकी एंटीबॉडी जाके रिएक्शन करती है अदर आई में, तो उसके कारण ये भी रिएक्शन, इस आंख में भी रिएक्शन शुरू हो गई है। तो इसको हम लोग हमारे मेडिकल टर्म में सिंपैथेटिक ऑप्थेल्माइटिस कहते हैं। अब ये बीमारी हो गई है। ये बीमारी अगर समय रहते तुम अगर इलाज लेते, गांव में नहीं दिखाते, लाल हुई तुमने दवा डाल ली, लाल हुई दवा डाल ली, समय पे यहाँ आकर दिखाया नहीं, पेरिफेरी में यूँ लेते रहे अपनी मर्जी से, या जिसने कोई ने दे दी उस हिसाब से, इसलिए बीमारी बढ़ गई है। अब ये बीमारी सूजन इतनी बढ़ गई है कि पर्दे में भी फैल गई है और आगे तुम्हारे आंख के आगे वाले भाग में भी फैल गई है। इस वजह से तुम्हारे आंख का जो दबाव है ना वो भी बढ़ गया है और वो काला पानी बन गया है। तो इस वजह से नजर और कम हो रही है। तो अब पहले इसका जितना जल्दी इलाज करते उतना जल्दी रोशनी बचती। अभी भी हम कोशिश करेंगे जितना हो जाए, पर तुमने समय रहते इलाज नहीं लिया और इधर उधर करते रहे, इसलिए तुमने इसमें समय की बहुत जरूरत। समय पर इलाज अगर ले लेते तो आंख बचाई जा सकती थी, रोशनी बच सकती थी आपकी। अब देखते हैं तुम्हारी जितनी रोशनी बची हुई है उतनी कितनी बचाते हैं हम, और आगे दवाइयाँ देखते हैं।
So this was an informative video on the topic sympathetic ophthalmitis. It is a rare incidence but is often misdiagnosed even by medical professionals. If diagnosed and treated on time, the patient can have, at least 50% of the patients can have 20/40 vision at least in one eye. I hope this video was informative and helpful to you all. Thank you.
Thank you so much for a very informative reel. I would like to invite Dr. Vaishali ma'am for comment.
Very nice video. Brings home a couple of points. One, there is no role of torchlight examination in uveitis. And second is that if you don't understand, don't take the complaints lightly. Simply because you are not seeing redness or you are not seeing cell doesn't mean the patient doesn't have a complaint. So always take complaints seriously. And the third one is please never say that the previous doctor did not manage it well. Probably he or she did whatever best they think they could, and things like this could be very detrimental for someone's career. So I think we should be very sensitive of saying anything to the patient, but a very informative video. Congratulations.
Thank you so much, ma'am. So shall we proceed towards the third reel? Sahil sir. Okay, so the third reel is from 2020 Visionaries.
Uveitis refers to a range of conditions that cause inflammation of the uvea in the eye. It can be of further subtypes: anterior uveitis, inflammation of iris and pars plicata; intermediate, where there is inflammation of vitreous including pars planitis; and posterior, where there is inflammation of retina and or the choroid. And when all uveal structures are involved, it is called as panuveitis. Symptoms of uveitis includes redness, ocular pain, photophobia, blurred vision, floaters, and decreased vision. Among the causes, the most common is idiopathic, while the other causes could be infectious like tuberculosis, syphilis, varicella. Non-infectious causes could be HLA-B27 associated, juvenile idiopathic arthritis, sarcoidosis, etc. And in masquerading causes, it could be neoplastic as well as non-neoplastic causes. For the investigations, we go for HLA tissue typing, serology for syphilis, Lyme's and HIV, ESR, CRP, CBC levels, chest X-ray, sacroiliac X-ray, interferon gamma release assay, and many more investigations. Ocular imaging can be done in the form of B-scan, OCT, fluorescein angiography, autofluorescence, etc. And finally, referral to a specialist physician according to the etiology. For the treatment, we have to give steroids, which are the main mode of treatment. It can be given in the form of topical, subconjunctival, regional, intraocular, or systemic. Along with it, cycloplegic agents are given, and immunomodulatory therapy is given in the form of antimetabolites, alkylating agents, and biopharmacologicals, which are also given as a steroid-sparing measure. Finally, if they are left untreated, it can cause complications such as retinal scarring, glaucoma, cataract, optic nerve damage, retinal detachment, and permanent vision loss.
Thank you so much for your reel. So I would like to invite Dr. Tinku ma'am for the comments.
I think you put in all the information that a patient would need, very relevantly in your presentation. Just one thing, try not to have watermarks on your slide, like your slide was showing a watermark. So there are a lot of other, apps and video making platforms which do not have these watermarks. That was a bit distracting, the watermark. Otherwise, very good presentation.
Thank you so much, ma'am. So can we move to the next reel, Dr. Sahil sir? So our next reel is from the Site Squad.
Early detection, adequate treatment, protect your vision.
So it was very beautiful action reel. I would like Dr. Mayur sir for the comments.
Yeah, again, an excellent. I actually like this entire idea of these reels. It's keeping us entertained. I can see everybody smiling there. And for this one, definitely a very good patient education reel again. And I liked the way that UVEA came and did that over there in middle. Thanks. Very good. Very nice.
Thank you so much, sir.
Yeah.
So coming to the next reel. So the next reel is from the team Arts Triangle.
Two hours later.
Please sit down. What happened? How did you get injured?
Road traffic accident.
When was this?
2 hours.
We'll have to examine you. It is an open globe injury and the ocular contents are coming out. We will have to take you up for surgery tonight.
The next day.
Okay, so we've successfully closed the wound. Please remember that you have the other eye. You have to protect it. Okay?
2 weeks later.
I am having blurring of vision from the left eye. I am not able to use my phone. I am seeing some black dots for the past few days. But doctor, the injury was there in this right eye. Why am I experiencing these things in the left eye?
Let me take a look. Oh no! What do you think has happened here?
Yes, you have guessed it right. It is a case of sympathetic ophthalmia. Sympathetic ophthalmia is a bilateral granulomatous panuveitis which occurs following surgery or penetrating trauma to the other eye. The symptoms usually start from 2 weeks to many years following trauma or surgery. It is due to immune dysregulation where a cell-mediated immune reaction is directed against self-antigens. Patients present with pain, photophobia, photopsia, floaters, decrease in accommodation, near vision. Clinical picture includes bilateral acute anterior uveitis with mutton fat KPs, thickening of iris and synechiae, increase or decrease in IOP, white-yellow lesions at RPE corresponding to Dallen's nodules at equator and beyond. Its management includes high-dose steroids and immunosuppressives as early as possible. All in all, through this video, we wish to highlight the importance of patient counseling and timely management of this dreadful complication. Thank you.
Thank you for the beautiful reel. I would like Dr. Somova sir for the comments, please.
So first of all, let me tell you that you all are natural actors. So you can certainly try in Bollywood also because your acting skills are very good and very much creative. I think YOSI should take this reel for mass education to have another channel if there is a channel for the mass education. These reels are really very helpful. Thank you so much.
Thank you so much, sir. So shall we proceed to the last reel? So this reel is from the Sight Seekers.
समाज की रूह को छूने वाला प्रस्तुत है आज की खास पेशकश, आंखों की जंग और रीढ़ की जकड़न।
शाम का समय, डॉक्टर अंजी का क्लिनिक।
ऋतिक, आज क्लिनिक में जितने भी पेशेंट्स आएंगे मैं चाहती हूँ उनके डिस्क्रिप्शंस तुम लो।
यस मैम, श्योर मैम।
अंदर आ जाओ मैडम जी। आइए ऋतिक, पर्चा ले लो, हिस्ट्री ले लो। अरे जल्दी जल्दी चलो बिटिया, ऐसे चलो तो ससुराल में नाक कटा दोगी हमें। लो बाबू साहब, ये लो पर्चा।
डॉक्टर अंजी, गौर से मरीज की चाल देखते हुए।
बैठो बैठो यहाँ।
बताइए उनकी आंख में क्या तकलीफ है?
अरे ये क्या बताइए बाबू साहब, हम बताते हैं। 4 दिन से अखियां लाल है इनकी। पहले भी 2-4 बार ऐसा हुआ था, तो सामने की दुकान से गिरा लाकर इनको दे दिया मार, तो ठीक हो गई मानी। परंतु इस बार तो हमारा नाक में दम कर दिया है। अरे लाइटर वाला भी इनकी खूनी आंख देख के भाग गया। अब बताओ हम क्या करें इस बिटिया की?
जब आंख लाल होती है तो साथ में कीचड़ भी आता है या दर्द भी होता है?
बेटा तुम्हारी कमर में कब से दर्द है? अरे ये क्या पूछ रहा हो मुझे? तुम पहले बिटिया का आंख ठीक कर दो बस। ऐसे तुम गठिया विभाग वाले डॉक्टर साहब दवाइयां पे दवाइयां चलाते रहा, पर देखो हमारी बिटिया एकदम कुपड़ी हो गई हो। अरे अम्मा, इनकी कमर का दर्द और आंखों की बीमारी एक दूसरे से जुड़े हो सकते हैं। मैं अभी आपको समझाती हूँ। ऋतिक, असेस कर।
डॉक्टर ऋतिक, स्टेनिस पर विजन करते हुए।
यार बस सामने क्या दिख रहा है?
ना दिक्कत है।
ऊपर का अच्छे से नहीं समझ में आ रहा है? दूसरी आंख से देखिए, सामने ऊपर समझ में आ रहा है?
ना दिक्कत है।
Oh my God, such a low vision at such a young age. Ma'am, I think you need to look into this.
I suspected that. अम्मा, सुनिए, आंखों का बार बार लाल होना खतरे का संकेत हो सकता है। इसे नजरअंदाज करना आपकी रोशनी के लिए काफी घातक साबित हो सकता है। अक्सर जोड़ों का दर्द या कमर का दर्द आपकी आंखों की बीमारी से जुड़ा हुआ हो सकता है। इसीलिए सजग रहिए और अपने नेत्र विशेषज्ञ से परामर्श लीजिए। हमने तो अपनी बिटिया के इलाज में बहुत देर कर दी, पर तुम ना करना ऐसा बाबू साहब, गलत होगा।
As a young ophthalmologist, I shall always remember, every red eye is not conjunctivitis. Recurrent uveitis is a puzzle waiting to be solved. Stay sharp, stay curious.
Thank you so much for the beautiful reel. After seeing this reel, I must say that के डॉक्टर मरीज की चाल देख के इलाज बता देता है और मर्ज बता देता है। मुझे वो कोट याद आ रहा है। So I would like to invite Dr. Athena ma'am for the comments, please. Ma'am.
I think ma'am is not there. So we can probably have comments from Vishali ma'am for this reel. Yeah.
No, I just loved it. Great acting.
Amazing
So,
actor.
yes. So with this, we come to the end of the first two rounds where our judges, they've sat through more than 2 hours wholeheartedly with us. I would request all the judges to mark the Excel sheets and send the filled sheet to Dr. Sahil's personal message so that, we can collate the marks. And we would love if you can stay back for we have 2 more rounds to go for Unscramble and Quiz. But we would love if you can stay back, but we know we've kept you long enough on your Sunday afternoon. So thank you so much. A huge thank you to all of you for your, wholehearted participation. So we have a quick, small memento vote of thanks from us. So these are the certificates. Dr. Sahil gets to Ratinam Madam, Dr. Vishali Ma'am, Dr. Mayur Sir, Dr. Tinku Ma'am, Dr. Somava Sir, for your wholehearted participation. And before we, you all log out, we'll take a quick group photo to just go, for having this memorable thing, and a quick word of, closing remarks from all of you. So I'll request everybody who's there in the audience and the teams to quickly switch on your video. And Mr. Sai, if you can take a quick screenshot for us. Mr. Sai, are you there?
Yes,
yeah.
Just a moment.
Yes. I'll request everyone to quickly switch on their video, whoever is there. All the judges,
all the team members, quick, please.
Yes. And we can do this
all the
YOSI
mentors
sign.
also,
Yes. We can do this YOSI sign that we, do.
I have balloons.
Dr. Vishali has
Yes.
balloons.
Yeah.
Mr. Sai, we can take the screenshot. Is it done?
Thank you.
Thank you. So quick comments from the judges before we, any feedback or anything. Vishali ma'am, we can start with you. I know you have another meeting to attend. So
I think it's an excellent venture. Very nice to see youngsters getting involved in UVEA. So I think after each presentation, you should have a commentary by an expert who can kind of differentiate the theoretical knowledge from the practical knowledge, because uveitis is not what West teaches us. It's very different in India. Well done, Team YOSI. Wonderful adventure. Thank you very much for making me a part of it.
Thank you, ma'am. And I hope that you will encourage your residents as well to register for this.
Sure.
Yes, ma'am. That would be, thank you. Thank you. Ratinam ma'am.
It is fantastic. I really enjoyed all the sessions, except the last one, which was fully in Hindi. And I'm very unfortunate, I didn't understand. I have not marked for that. But everything was wonderful. I'm very, very happy that I was with you. Thank you.
So I think that's a tip for all the participants in the future. Whenever you're making a reel in Hindi, always have subtitles in English.
Subtitles are very important.
Yes.
Especially for people from Tamil Nadu.
Yeah. No, overall also, ma'am, I think this is how they're learning, ma'am. That's what is a learning thing for them. Yes, ma'am.
Thank you.
Thank you, ma'am. Tinku, ma'am, your thoughts on the session?
Yeah, I think it was one of the most interesting and entertaining webinars that I've attended till date. So all the young people, their knowledge was up to mark, and especially the reels was such a unique and innovative idea. I thoroughly enjoyed it. Thoroughly enjoyed it. Thank you so much for making me a part of this.
Thank you, ma'am. Dr. Mayur, sir, your thoughts on the session?
Excellent, and thanks for having me as a judge here. And I didn't miss the Sunday afternoon reel scrolling thing that I would generally otherwise do. So thanks for having me here. Thank you very much, and congratulations to all participants and their mentors. Great work, and thanks you. Great plan.
Dr. Somava, sir, your thoughts?
So rather than judging, I have learned so many things. So rather than giving some gyan to youngsters, I am learning from the stalwarts of this UVEA session. So just a big thumbs up for YOSI. You rock it. You really rock it. Thank you.
Thank you. Thank you once again so much, judges, for taking your time out. We are so honored and privileged to have you all join. We learned from so much from you all, and I'm sure those who are watching on YouTube will watch in the future. Will also get to learn so much. And thank you for being there so wholeheartedly throughout. For both the rounds means so much to us. Thank you so much. And also, I would like to also congratulate and shout out to all the participants. You're not just at your residency level, but great job. It takes a lot of efforts to have the courage to come and present in front of the stalwarts. So whatever comments the judges have given, just take it as a learning point, and I'm sure the judges echo with me. So thank you so much to all the judges. Thank you so much. And as I mentioned, I would request all the judges, any residents known to you, you can just push the residents to, we want residents to come up and participate in this. That's the whole idea, to give a platform to all of them through YOSI. So if you can just encourage them, I'll be sharing the link with you on the WhatsApp group also. So you can just share it with your residents as well. So that would be great.
Thank you.
Thank you so much.
Thank you. Thank you, everyone.
And you can just share the Excel sheets with Dr. Sahil. We'll collate and announce the results. So,
goodbye.
Goodbye, ma'am.
Thank
Goodbye, ma'am.
Thank you.
Goodbye.
Thank you, all the judges.
Yeah.
Thank you.
Thank you.
So, over to you, Dr. Sahil, Ritu, and Priya for the next 2 rounds. I will have to take a leave because, yeah.
Thank you so much, ma'am, for joining in.
Yes. All the best to all the participants. Be very careful in the quiz, and your scramble, they could be game changers in your first, second, third positions. So be very careful. I'm sure Ritu, Sahil, and Priya will
Yes,
help
ma'am.
you in that. Yeah, over to you guys. Yeah.
Thank you, ma'am.
Thank you so much, ma'am.
Quickly move to round 3, keeping the interest of time. All the
Yeah, Dr.
participants.
Ritu, just before we start, I mean, just tell me, will you be sharing it from your side? Because
No, you may continue. I
okay,
will
so
read
then
out. Yeah, thank you so much.
the timer will be managed from your side, or
Yes,
Priya,
yes.
ma'am, Dr. Priya will manage. Dr. Priya, please take care of the marks as per chat room and the map.
All right.
Okay.
So round 3 is titled Knowledge Nexus, and we'll have all the specialty questions here, not just UVEA. So buckle up, guys. Next slide, please. You have the following rules. You already know that you have one pre-decided team member. So we have got 10 questions for you with mingled up 3 audience questions. All the questions will be projected by Dr. Sahil, and you'll be given 20 seconds. So each team has remembered their team numbers. Team 1 for Vogt's trio, Team 2 for Visionaries, Team 3 for 2020, Team 4 for Side Squad, Team 5 is Arlt Triangle, and Team 6 is Site Seekers. It's so much like fastest fingers first, and you shall be putting up your team numbers 1, 2, 3 accordingly after I read out the questions. Team Visionaries, I'll have to ask you to mute. Team Visionaries. So once I read out the question, type in the chat box your concerned team number, and only when I ask you to unmute, you'll have to answer the question. If you fail to answer that question, or you give an incorrect answer within 10 seconds of that stipulated time, you'll get a negative marking, -2 on your side. If you give a correct answer, it fetches you +1. Also, there would be 3 audience questions where the teams will not be putting up any team number. Audience will be typing in I in the chat box. I'll ask the audience member to unmute and then they can answer. Each of the audience members who gives the correct answer can win exciting prizes. So stay alert, audience and team members, both of them. Please go ahead, Dr. Sahil. There's one trial question for you all. Where is Charminar? A. Agra, B. Delhi, C. Mumbai, or D. Hyderabad?
It's 1, ma'am.
No. Okay, yes, it's 1. So both trio, you can unmute yourself and please give an answer.
Ma'am, D. Hyderabad.
All right. So this is how it functions. And after you have given your numbers, Dr. Priya is going to type XXX or 4Xs to tell you guys that you cannot type in your team numbers ahead, and we'll move with the next question. So once she types the XXX, please do not type anything on the chat box. The instructions are crystal clear and we'll go ahead. All the best. Structure passing through the tendinous ring of Zinn are all except A. Optic nerve, B. Abducens nerve, C. trochlear nerve, or D. Nasociliary nerve.
Ma'am, it's 5. Arlt triangle.
Arlt triangle, please unmute and give the answer. Team Arlt triangle.
I think time up.
Next team.
6. Team side seeker.
Ma'am,
Okay.
A. Optic nerve.
Sorry, team. You had 10 seconds. So,
Hello.
yes. Team Arlt triangle, you were supposed to unmute.
Multiple times, but the voice is not.
I'm sorry. I still can't hear you.
For this question, I think the team 6 has already answered. I think we'll go to that.
All right. Moving ahead with the answer.
Yeah.
Ma'am, should I answer?
Yes, please. You did answer, I guess.
Team 6 answered wrongly. They answered, but they answered wrongly. So
A -2 for them.
-2. Okay. Next question.
Yes, next question, please. Which of the following metabolic disorders is most commonly associated with bilateral cataracts in children? A. Wilson's disease, B. galactosemia, C. phenylketonuria, or D. GSD, glycogen storage disorder?
The answers are coming up before the question is over of the team 2 and team 4. So I think team 5 should get again the option because team 2 and 4 started answering before the question was even complete.
Just to remind you people, you can fetch negative marks if you do not follow the strict rules.
Yes, because this last warning, after this we'll start with negative marks. So team 5 should answer.
Team Arlt triangle.
Answer is B.
I can't seem to hear them.
Answer
Did
is
you,
B.
Dr. Sahil?
They said B.
They said B. They get a +1. Yes,
Yeah.
all right.
Okay, so next. This is the audience question.
Audience question. No teams shall put up anything on the chat box.
Only
So
the audience, whoever there. I. They have to put up I.
Which substance does not cause crystalline deposits in the retina? A. Thyroidazine, B. Canthaxanthin, C. Tamoxifen, and D. Talc. Anyone from the audience? You can type in I.
So
Dr.
there is
Noor.
Noor Nisha.
You can please unmute yourself.
I'm tamoxifen.
Okay. Let's look at the answers. It's A, thyroidazine. Rest all are culprits of crystalline retinopathy. No negative markings for you, Dr. Noor. Don't worry. So we move to the next.
Team, any team, if they are, when we ask them to unmute, and in case their voice is not audible to us, we'll mention it, so that if it's not audible, you can just type on the answer, but only once we tell you to unmute, not before that, because first is audio feedback, second will be typing feedback. So now so Dr. Ritu.
We have the third question now. What is the primary lesion location in INO? A. Oculomotor nerve. B. Medial longitudinal fasciculus. C. Abducens nerve nucleus. Or D. Lateral rectus muscle. Dr. Priya?
Ma'am, I think everyone has answered before the question is over. So we should give chance to the team B Visionaries because they replied after the question is over only.
Ma'am, answer is medial longitudinal fasciculus.
Okay. Moving next to the... Yes, it's right. Team Visionaries. Next question, please. Test to measure AC by A ratio include all except A. Heterophoria test, B. Gradient method, C. Fixation disparity method, or D. Scobie-Burian test.
Team 4.
Okay, Team 4 side squad, please unmute yourself and answer.
Scobie-Burian test. All except Scobie-Burian test.
You're right. You get a +1. Dr. Priya, XXX, yes. Move to the next question. Name the disease as depicted in the pictures. A. Cryptococcus, B. Tuberculosis, C. Sarcoidosis, or D. HIV.
Team 2 Visionaries.
Please unmute yourself.
Ma'am, it is the depiction of, I think, sarcoidosis.
And yeah, your answer is correct. You fetch a +1. Team audience, next question for you people. The finding most predictive of the visual acuity in a patient with PDR is microaneurysms, macular edema, cotton wool spots, or intraretinal microvascular abnormalities.
Team, this is an audience question.
We will request the audience to type I. No teams shall type their number.
Anyone in the audience?
Dr. Sampoor Naraj.
Okay. Please unmute yourself and give the answer. Finding most predictive of the visual acuity in a patient with proliferative diabetic retinopathy.
Macular edema.
Wonderful. That is right.
So
next question for the team.
Yes. Okay.
Question number 6 is, which anti-VEGF drug has a dual action mechanism targeting both VEGF-A and angiopoietin 2? A. Ranibizumab, B. Aflibercept, C. Faricimab, and D. Pegotimnib.
It's team A. It's team 4 site squad.
Okay. Team site squad, please unmute yourself.
Option C, Faricimab.
Good. You get a +1. Next question, please. All of the following are recognized complications of glaucoma tube shunts procedures except A. Hypotony, B. corneal neovascularization, C. conjunctival melt, and D. diplopia.
Team 2 Visionaries.
Please unmute yourself,
Ma'am,
Team 2.
Ma'am, answer is corneal neovascularization. Option B.
All right. Your answer is right. +1 for Team Visionaries. After finishing phacoemulsification on a dense cataract, the surgeon notes whitening of the clear corneal incision. What do you think would be the most likely cause? A. Tight incision, B. High aspiration flow rate, C. High phaco power, or D. 45-degree bevel phaconeedle.
Team 1 Vogt trio.
Team 1 Vogt trio, please unmute.
High phaco power.
Okay. The answer is incorrect. You get a -2 here. The correct answer was a tight incision. Question number 9. All of the following are advantages of a CT imaging compared to MRI except A. Ability to detect metallic foreign bodies. B. Images are generated more quickly. Better definition of the chiasma. Or claustrophobic patients can tolerate it better.
Team 4 side squads.
Team 4 type. Okay. Side squad, please unmute yourself.
Claustrophobic patients can tolerate better.
Okay, you mean to say D. That's incorrect. Correct answer is better definition for the optic chiasma. Next question. You get -2. The most common cause of unilateral proptosis in a middle-aged woman is A. Cavernous hemangioma, B. Thyroid-related orbitopathy, C. Dermoid, or D. Metastatic breast carcinoma.
Team 6 side seeker.
Please unmute yourself.
Thyroid-related orbitopathy.
Okay, you answer B, and that is the right answer. +1 for side seekers. Audience, last question for you. Which test may be useful in a patient with bilaterally narrow anterior chamber angles and normal IOP? A water drinking test, prone darkroom test, supine lightroom test, or a dexamethasone provocative test? Please type I.
Dr. Sampurna Raj.
Please unmute Dr. Sampurna. Fastest fingers in the
Prone
audience.
darkroom test.
Prone darkroom test. Okay, that's the right answer. Congratulations. You get 2 exciting prizes.
Great. So
We end the round 3 here, and we have noted the pluses and minuses you guys have received in this round. This is your last round, and you can still turn tables. The last round is Wordsmith War. The rules are as follows, that one by one, I shall be projecting the questions as a PowerPoint PPT, and you will be playing it accordingly. 6 jumbled words will flash on your screen, and you'll have 1 minute to solve as many words as you can. Each word will give you one positive mark. There are no negative marking. All the best, team. We'll have one trial round before that, such as these. The words here are non-ophthalmology related. So we'll give you 1 minute to unscramble these. In the interest of time, we can move ahead, Dr. Sai. And these are the questions. So when you're given the time, you shall unscramble. Then after the stipulated time is over, we'll present you with the answers. Let's move ahead. The first team.
Team Vogt trio. Please keep your
I am
unmute.
Just a second. Who is with the timer? Dr. Priya, are you?
Timer, please.
Ma'am?
Yes.
Dr. Sahil, can you please see the timer because I'm not able to see that.
Wait, just hold on.
It's okay.
Yeah, okay. I'll make sure of it. Let's start.
क्या हो रहा है?
हो गया timer start. Vogt trio start solving.
Lacrimal gland tumor. First, lacrimal gland tumor.
Okay.
Second, adenocarcinoma. Third, Steven-Johnson syndrome. Fourth, Waardenburg syndrome. Fifth, Irwin-Grass syndrome. Sixth, Poschner-Schlossman syndrome.
Let's move ahead.
So, okay.
Time.
All correct.
Very good.
Very good. All correct.
All good.
Next team.
Next team will be the Visionaries. The Visionaries. Okay, be ready. Unmute yourself. Other, please keep yourself mute.
Start. Team Visionaries.
Team Visionaries, are we audible or you are not audible because?
Yes, yes, sir. First one
Okay.
is Axenfeld-Rieger syndrome. Second one is
Go to others.
third one is Sirim Bombay, Iris Bombay. Third one is Iris Bombay, and fourth one is sphenoid fifth one is capillary hemangioma. Sixth one is convergence anomaly.
Time up.
Time up.
I guess they got 3 right.
3 right.
3 right, yes.
Yes.
Participants, you have to turn on your videos. I can't seem to find you.
Next team is 2020 Visionaries.
Please turn on your video.
Start.
Sturge-Weber syndrome. First one is Sturge-Weber syndrome.
Okay. Problem.
Ring. Iris retractors.
Very good.
Ring something.
Come on, come on, come on.
14 seconds left. Come on.
Bates ring.
Chalo, let's give it to them. Done.
Time up.
3 correct.
3 correct.
4.
Next.
Team 4, switch on your video.
Yes, side squad.
Start.
Sometimes ignored syndrome. 5 is Weber syndrome.
Sorry?
Hello?
5 is Weber syndrome. I just had. Okay.
Okay.
Just one person to answer. Third is Dr. Sahil. Could you hear them?
No, no.
No, I can't hear them.
You can type if you are having issues, just type it.
I could just get one answer.
Yes, only one answer.
From your side. 5 more seconds.
One is Bird syndrome.
Okay. 2. The answer 2.
Fifth is Weber syndrome.
Time up. Time up. Time up.
Okay. So 2.
Plus 2. Yes.
Plus 2. Okay.
Next team. Please unmute yourself. Switch on your video. Yes, you are audible.
These are all the answers. Now we are going to team 5. Arlt's triangle.
Start.
Beckett's disease.
One person at a time.
Food is Orboscan.
Team, you're not following the instructions.
Which one? Please answer first. One. What did you mention?
They answered orb scan for 5.
Okay.
Electron mass for 4. For 3. Syndrome for 2.
You are not audible.
Not audible, team.
Please type. You are not audible.
Time is up.
They have written one answer.
Budget.
+2 for them also.
+2.
Okay.
The last team, please be ready.
Madam, Dr. Ritu, they have written one more answer. See, actually they are,
Stop answering after
but
that.
stop now. What do we do?
It's not going.
Their audio problem is there. What do we do?
We
You
should
still
give
have
mark,
the
I think,
question.
ma'am. We should give mark to them because their
And
audio has some problem, ma'am.
Yes, ma'am. I do also
keeping
think.
that
+3.
into account, we'll give them +4.
+3.
Beshex,
+4.
Claude, Eller, Danlos, and Orbscan.
4.
Yes.
4. Okay.
Yeah.
+4 to this team.
Okay.
Please check your mic first, team site seekers.
Yes, that's why we
Yes,
are
ma'am.
telling. Because everybody in
And be
during.
louder. This is
Yes,
why
ma'am.
we have
Ma'am, can you
mock
hear me?
trials for you. Yes,
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 you're
we can hear
audible.
you.
Yes.
Good.
So
Yes.
site seekers, be
Go
ready.
ahead.
Yes, ma'am. Pupil. Oh, the third. These pupil. First is pupillary reflex.
Okay.
Second is pupil. Third is scotoma.
Okay.
Third is scotoma. I'm thinking of second. It's pupil, but I can't. What is this? Scotoma. What is the pupil? Second one. Fourth is
10 more seconds.
hemianopia. Fifth is herpes simplex. Sixth.
Time up. She almost had the second one. But there are
+4.
no half marks.
+4.
Great.
+4
I guess
marks.
it was
Yes,
just team 1 who were on their toes, but you guys did great considering all the rounds. I loved how you were till pupil and then you couldn't decode the area.
Thank you.
Unfortunately, we don't have half a mark here, so it won't be counted. Dr. Sahil, you can wrap up the session and we'll have a quick
Okay, so well, I hope all the
photograph.
residents have enjoyed. Just a second. Yeah, so I hope all the residents have enjoyed to the best possible. We have tried our best. The team under the guidance of Dr. Nupur ma'am has tried their best to give it a very good experience to you all guys. And these are the certificates which we would like to present to all the team: Dr. Punya, Dr. Diksha, Dr. Alam Sohana, Dr. Priya, Dr. Bhavna, Dr. Sumita, Dr. Nibha, Dr. Shreyaraj, Dr. Preeti, Dr. Shine, Dr. Anjita, Dr. Aisha, Dr. Kirtana, Dr. Pooja, Dr. Aniket, Dr. Anvi, Dr. Ritik, Dr. Anji. So I hope everybody has enjoyed a lot. Before we end up, we'll be having a small group photo. So everybody should switch on their videos, and please switch on the video so that we can have a screen shot. And remember, please, 5th to 7th of September, we have YOSICon conference. As a budding ophthalmologist, budding residents, I'm telling you, I don't know how much you are exposed to YOSI, but if you explore the Young Ophthalmology Society of India and YOSI, you will be having a very, very, very good platform for many kinds of academic and even non-academic entertaining things. So you should explore it, exploit this platform, because this is the upcoming platform. Not everywhere you will get such opportunities. Not everywhere you'll get things to present so easily. Not everywhere you get to showcase your talents. So you have slide shares, you have late night retina session, you have cataract sessions, you have other subspecialty session across the UC platforms, which you can very well do it as a kind of academic hobby. So I hope everybody enjoyed, and let's switch on the videos for the last photograph.
One final photograph.
Some any comments from the participants and all the residents. So please, team, all the team, please switch on your videos. Yes, all staying at side squad, Visionaries, everyone, please.
Wonderful
Audience,
job, guys.
Audience.
I love their smiling faces.
Yes, they are
I
happy.
remember in the mock trial, Dr. Shainet asked if we can put up something in the another language apart from Hindi. Do we go about with the subtitles? And I guess
Yes.
that had to be taken. That advice was not taken by the site seekers. If you had, it would have helped you people. Team Side
Yes.
Squad, Team Votes Trio. Please switch
Yes,
on.
please switch on.
We're
Very
going to
soon
wrap
we
up
will
real
have.
quick. It's been 3 hours.
Sir, please
Yes.
take screenshot very.
What a marathon you guys had. And Mr. Sai is with us.
Yosi, sign.
We'd like to thank every one of you for the opportunity and thank you for keeping the reels round because we realize that we are really good artists and we want to go into the whole dramatics part as well. So
Yes.
thank you so much and please continue having this so that we can participate in more such events.
Sure.
Kindly share your reel so that I can viral them.
Yes, ma'am. Sure, ma'am.
Yosi sign. I don't know where what's try.
Screenshot, group photo.
Mr.
Sai,
Sai.
let us know.
Done.
Thank you.
Thank you so much.
And residents, please invite more of your friends, colleagues, senior, junior resident. The preliminary sessions are still on. They have opportunity to more participate, and I'm pretty sure they'll get. You can help them in getting more artistic with your experience. And okay, so let's.
These faces are going to come and compete for iROCK stars, superstars. All the
Yes.
best to you all. And Dr. Sahil, did you note the names of the audience prizes?
Audience, only one name.
Dr. Sampurna.
Sampurna Raj was the only person.
And the first, okay, she was all
both,
right.
both the answer. First was not answered. It was wrong.
Yes.
The second and third was Dr. What do we need? What details do we need from
I've
Sampurna?
taken his contact number.
Okay, that's it. That's it. So fine. Okay, guys, keep enjoying entertainment and studies. Okay. So
Congratulations to all and all the best. Thank you so much. Thank you.
Thank you, Dr. Priya. Thank you, Dr.
Thank you,
Ritu.
Ritu madam. Thank you, Sahil sir, for the cooperation and screen sharing till last round. Thank you so much, sir. And I
The
would like
results will be out by 8 p.m. We can
Results
stop the
will be
live
out.
share.
Yeah, sure. Okay, sir. We can leave the meeting, right? Okay.